अरे संदीप, संदीप, मैं शेयर करूं स्क्रीन एक बार?
आप ट्राई कर सकते हैं।
एक बार शेयर करके देखें। शेयर करूं? शेयर हुआ? शेयर हुआ? शेयर हुआ? शेयर हुआ नहीं? शेयर हुआ? संदीप, संदीप, संदीप,
आपकी वॉइस आ रही है।
संदीप,
मैं आपको थ्योरी कर रहा हूँ।
संदीप, हाँ हेलो। अच्छा अच्छा, हाँ एक बार ट्राई करके देख लें। इसमें इसमें रहने दो। एक मिनट, मैं दूसरा डिवाइस ले रहा हूं। मैं दूसरा डिवाइस ले रहा हूं, जस्ट होल्ड ऑन। मैं दूसरा 831, मैं दूसरा डिवाइस ले रहा हूं। हेलो। संदीप, मैं दूसरे डिवाइस पे आ गया हूँ। हाँ संदीप, आया? तुम्हारी आवाज नहीं आ रही। आवाज नहीं आ रही।
सर हमारी आवाज देखिए।
हाँ, अब आई, अब आई।
ठीक है, तो आपकी स्लाइड्स विजिबल हैं, आप भी विजिबल हैं।
अच्छा,
बस थोड़ा सा आपको स्लो बोलना है सर।
ठीक है।
आपको थोड़ा स्लो बोलना है क्योंकि जो यूट्यूब पे होगा वो थोड़ा 10-20 सेकंड बाद में जाता है जो YouTube पे।
अच्छा अच्छा।
तो लोगों को कोऑर्डिनेशन थोड़ा अच्छा होता
हाँ, तो वो कितना कितना डिले होता है, कितने सेकंड्स का?
है, 10-20 सेकंड तक,
अच्छा
20
अच्छा,
सेकंड तक।
ठीक है, ठीक 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 ठीक। हम्म। अब मैं वो कर देता हूँ। अब अनशेयर कर देता हूँ।
हाँ सर, आप मैं आपको पहले 15 मिनट इंट्रोडक्शन रहेगा, तो मैं बोलूँगा, उसके बाद दोबारा से बोलूँगा और उसके बाद वीडियो चलेगा। Yes.
हाँ, अरे संदीप, वो तो क्वेश्चंस तुम लोगे ना, वो चैट बॉक्स पे जो इन लोगों को कह दिया कि चैट बॉक्स पे ही लिखें, है ना? तो वो जब तुम मॉडरेट करोगे एट द एंड, लगभग 10 मिनट के लिए, तो जो भी सवाल आए वो फिर मतलब फिर भेजते जाना, है ना? तो ये फॉर्मेट रहेगा। ठीक।
ले ले।
Unmute. Sandeep, please unmute.
Just 2 minutes, sir. 3 3 p.m. So we will start in next 2 minutes. I can also now participate. Yes. Should I start? So very good afternoon and welcome to the 9th SGPGI Postgraduate Anesthesiology Refresher course that is holding for 9th time since the beginning. Meanwhile, the course started, it has a different name. As we evolve, uh, we came to have this common name so that people don't have conflict with the other PPA assemblies happening all around India. So this Spark 2021 is a 4 to 10th April, and we are doing it in a very feasible time so that the students can join, because every resident has to work in the morning in the OPs. So we will do it for all 7 days. First 6 days it will be 3 p.m. to 8 p.m. and the last day is the Saturday on 10th April. The course will be from morning 9 a.m. to the evening 7 p.m. So I welcome all the participants. We have around crossed more than 1,000 registration. I will say it is 1,010 now, and we are very thankful for the participant from all over India, that they have shown very overwhelmed response. And our faculty, we have a distinguished faculty from all over India, from prestigious institutes. Those are already PG teachers, and not only in MD, also in DNB exams, and they understand well what a student, MD or DNB or DA student needs for passing exam. So we have the content of the course is specially designed accordingly. It focus especially the cases that you will get in your practical and biopsy examination. Besides in theory examination, there are 4 papers, and to cover that, like basic science, clinical science, and recent advances. Our faculty will also cover all these aspects, although we assume that the exam going back almost this is April, and April, May is the exam time all over India. If COVID doesn't stop us from giving exam or delaying exam, then I think most of the exam will be between 15 April to 15 May, the theory exam. And for that, we request all that you read from the standard textbooks. I will overview the course. Today is the day one. Day one will start the first thing, how to appear in theory and practical exam. This to be taken by Professor Privat Tiwari sir. Then after you understand how you to appear in theory and practical exam, the first thing to start is the pre-anesthetic checkup and perioperative optimization. Because in every case you have to write either management or anesthetic consideration or the case you will present, then this topic will come to every patient day and night. After that, the long case, that is approach and anesthetic management of a term pregnant female, that has 4 parts. First is physiological changes that to be taken by Dr. Ganpat Prasad from SGPGNS. After that, we have, you can get a patient of hypertensive disorder, PIH or eclampsia, that to be taken care by Dr. Usha Shukla. After that, to successfully clear that long case, you can also ask the obstetric emergencies, like the cardiac arrest during pregnant female or postpartum hemorrhage, how to manage that. That to be taken care by Professor Shaila Halim Madam, she is from Aligarh, AMU. Another combination of pregnancy and severe mitral stenosis, pregnancy with mitral stenosis, anesthetic management, that will be taken care by Dr. Puneet Khanna, who is additional professor in AIMS New Delhi. So this the day one will end. The day two we have pediatric cases. After pregnancy, the most important case that routinely in medical colleges we get a pediatric patient. So here the anatomical and physiological changes. After that, we have put in the cleft lip and palate and pediatric anesthetic consideration overall. The airway, the fluid management, the monitoring, and also another long cases that you can get the neck swelling in pediatrics that will be taken care by Professor Amitabh. So tomorrow also we have a mini inauguration where we get the our director and Dean S.K. Mishra sir and all the authority who are helping us to conduct this course. Then we will have very important discussion about difficult area, because any case you will take or given, even in theory exam, you may be asked to write different like algorithm for difficult area, extubation guidelines. So what are the recent and what they are and how you understand them well. This will help you not only in clinical practice but also writing in theory. And it will also always, any case when you take exam, it will come on airway, it will come on the PAC. And here we have Professor Mohit Ahmed from AMU and Professor Manpreet Singh from GMC Chandigarh. They will also discuss 4 important cases around bun contracture, TMJ and ankylosis, and airway management in phaseal maxillary trauma. The day 3, it will take topics like oxygen therapy, because now COVID, so right from nasal prong to thigh, that will be discussed here in oxygen therapy by Dr. S.S. Nath. And also you will be asked for multimodal pain management, acute pain management in theory or practical exam. So what should be approach and what you should write in theory and what you should tell in practical will be here. After that, we have a long case, approach to a cardiac case. This to be taken care by Prabhat Tiwari sir, and he actually teaches everything almost that is important for cardiac cases, especially he will also deal with that, the coronary artery disease here. And I think coronary artery disease, hypertension, this to be asked in almost all patients because every third patient is diabetic and hypertensive. We are on in the NRC. Hope the YouTube, the delegates are able to we can solve it. Hope we are telecasting properly. If anybody has any issue, then please inform. Or you can write down below the YouTube transmission so that the message will come to us also. So in continuation of the program, the day second, we have another long case approach to a obstructive jaundice that usually you get. These are not only the long cases, these are also one of the questions when we are discussing clinical anesthetic management in almost 2 papers. Then this type of long questions can come. And we have seen that in theory, and Dr. Tiwari will take us after my introduction lecture that how you should write and properly, that will be more better to discuss. The day 4, we have approach to a trauma patient, the resuscitation, because airway we know that we will more focus on the shock management. Then this trauma patient, if to be done orthopedic surgery, that upper limb or lower limb surgery, then this case will be taken by Dr. Chavi Saidal from Jhansi. Also, we will discuss trauma patient for laparotomy, because if patient is hemodynamic unstable, then laparotomy first and then the cold surgeries will be done orthopedic later on. First, and what to be done in head injury patients. So trauma patient with head injury, laparotomy, and orthopedic surgeries will be taken care. And after that, we have another long case on neurological anesthetic management that will have a supratentorial as well, any mass lesion in supratentorial or infratentorial, and also the pediatric patient for BP shunt, because hydrocephalus is one of the case I think everywhere is available, and this can be put in your exams. Also, it can be asked to write the anesthetic management. Then after on day 4, last lecture will be on anesthetic equipment. This is almost 2 hours, so new and old anesthetic equipment will be discussed by Dr. Das and Dr. Manta. And we will separately putting anesthetic trolley, anesthesia trolley and workstation. And besides that, the airway lecture will have also the equipment of airway that will be discussed there. The day 5, 8th April, there will be approach to X-rays that are important for anesthesiologists by Dr. Jafar. We have pulmonary function testing and interpretation by Dr. Deven Gupta, because that will be asked in free anesthetic checkup. We will have another long case approach to a large thyroid swelling, where once again the difficult airway and intra and post-operative and peri-operative management will be discussed. Day 5 also will have a long case on diabetes mellitus for lower. The day 6 will be start with the approach to perioperative fluid management, what fluid, how much to give, which type of fluid, and After that, there will be lecture on vaporizer that will cover the equipment and basics of inhalational anesthetic, pharmacodynamics and kinetics. There will be a long case on renal case, that will be a CRF patient. What is the sign, symptom, preoperative, intra and post-operative management? This will be patient for PCNL. And we have almost covering all type of cases, all age, sex, male, female, elderly patient, obese patient. So elderly male with benign prostatic hyperplasia for PURP, one of the most common case can get. And after that, there will be approach to a case of CA cheek and head neck cancer. So here also the anesthetic management and airway and post-operative consideration will be done. The last day is that day 7. This is the longest. We will start at 9. Here we will cover the ophthalmics, the approach and management of ophthalmic cases that you can get. After that, we will have approach and management of ENT cases, CSM and tonsillectomy. Then obese patient for laparoscopic surgery. Then ABG and electrolyte disbalance. And after that, we will cover the severe sepsis patient for nephrotomy and hemodynamic monitoring. And last, it will be anesthetic workstation and anesthesia machine. So this will be almost daily 4 to 5 hour interactive discussion like teaching, and we will be very happy अगर आप लोग क्वेश्चन पूछते हैं, बात करते हैं, ताकि हमको ये समझ में आए कि हमारे जो टीचर्स जो पढ़ा रहे हैं, जो हमारे स्पीकर्स हैं, they are very learned and they are very senior faculty members. और अगर आप लोग बात करेंगे तभी हम लोग समझ पाएंगे कि क्या प्रॉब्लम है, so that we can solve that problem here. Because the time you are giving us, it is very important. We know this will daily will start from 3 to 8 p.m. So now it's time to start our first talk, that is how to appear in theory and practical exam. So it's over to Professor Prabhat Tiwari sir. Professor Prabhat Tiwari sir is a professor here in cardiac anesthesia at SDPGI Lucknow, and he is very senior teacher and even my teacher, and he is very learned and we always benefit with his experience and lessons. So it's over to Professor Prabhat Tiwari sir.
Sandeep, I'm sharing the screen.
Sir.
Am I sharing the screen?
No, you have to share, sir. You have to share.
Okay, I share it. Right. Okay.
Yes, sir. Now your slides are visible to us.
Is it visible?
Yes, sir. Now the
is it visible? And I am audible also?
Thank you.
Okay, good afternoon, ladies and gentlemen. Well, this is a very Herculean task which Sandeep has taken. It's a long course for 7 days altogether. And well, it will be a benefit for all the DNB, MD candidates who are just nearing their examination. Well, for the next half an hour or so, we will see that the culmination of what all you have actually learned in the 3 years, that actually results in you getting degree or diploma or whatever. Because we have been involved in these examinations for a long time now, we slightly know what are the problems. And as you can see, the title is Writing Theory, though the title which is written in the program is How to Appear in Theory Exam. Well, In the lighter vein, I must say, you have to appear in person. And for practical also, you have to appear in person. But actually, it is how to write theory and how to present a case. So that's why I have built it a kind of inspirational talk, so that you just get some tips and bits from me, what actually examiners need and how you are going to impress them and how you are going to fetch more marks, because that is what is required out of it. And in fact, since NEET has started, the examination with which you enter in any of the courses, well, they are all multiple choice questions. So what has happened that they have increased your area, means the knowledge base has increased, because then only you can answer those questions. But what has happened is that how, after learning a lot, how to actually write it down so that the examiner understands what is running in your mind and how you are actually expressing what you have learned. So that lacuna is there. The same thing is everybody is so much engrossed in SMSing things, Two friends might be talking to each other only through SMS and also emojis. Now, well, still we don't have emojis depicting so many medical terms, right, accurately, so that we can use it. So still we are far from that. So we have to write it down. That is what theory is. And presenting cases means you have to really look into the eyes of the examiner, and he understands by your demeanor whether you know the case or not. So small information I'll give you as we just go through this talk. All right. So before that, because it is zooming on and it is on the social media as well, so I must say that the photographs and visuals used in this presentation, they are not by me. They are only for emphasizing the points teaching by the speaker, means me. The whole format and idea of presentation is mine. Well, there are no financial implications involved in this presentation. And also, I do not permit the recording and replaying of this presentation after the meeting on any platform or social media. Well, I think all of you must have, all these students must have born after 1979. But in that year, there was a big singer, Pink Floyd. He came out with a wonderful song. And that started with, we don't need now education. You see, you can straight away jump on it that, well, he says no education. So it's a very broad definition of education. What is actually education? It's only rota learning and cramming and writing, or understanding and have your own views. Actually, the gist of the song was that. And I like this song very much, right? It would give you thoughts to understand. And that is what's needed when you get trained by the side of the patient throughout for 3 years. And what else you need? You need a mentor. Means there has to be somebody who takes you in this course of 3 years down the line, so that he makes you to look beyond his shoulders. That is what's the meaning of mentor. Just imagine a child sitting on the shoulder of his father or mother. He actually looks beyond what the parents have seen. So what you need is actually a mentor, a good mentor. And you are lucky if you get a good mentor, you see, because you see this in this picture, the boy who's making this boy pee, he is actually the mentor, right? He has created a space for this person to work actually. So that is what a mentor is. Means he is there, but he is not there. That is the best mentor. So mentoring is very important. So always listen to your mentors. And what is there? I talked about knowledge. Knowledge is important. It is the power. You have to gather that knowledge throughout 3 years. Then ultimately you can succeed in writing in the exam or facing the examiner. So by any means, it's not like that. You just don't do anything throughout the 3 years, and ultimately at the end of the 3 years, you think that, well, you should pass in the exam. Let me tell you, boys and girls, no examiner intends that any of the students fails. Why? The reason is that in medical profession, examination is every day. You are facing a patient, that is the real examination. You are just preparing yourself for that. He'll be the ultimate person to test you on day-to-day basis. So knowledge is very important. Always remember, from the day one you have entered the course, you start gathering the knowledge. Read like anything. Learn as if you are going to live forever, as Mahatma Gandhi has said. And one more thing, I like this Hollywood hero, Johnny Depp, too much, because he has done lots of difficult characters. And when somebody asks him about the 4 questions of value in life, he only said that, well, you love whatever you do. So if you have joined the course, you love that. You love reading. You love to look at the patients. And once you get that connect, then actually you start reading about it. Do lots of collateral reading, gather education, and that will help you throughout the life. It is not only a 3-hour writing the exam. You have been through the exam for the last 3 years, and now the time has come only to test it. And confidence building is very important. Once you have gathered that knowledge, once you have interacted with your mentor, then you will find that, well, the confidence has come in. It comes slowly, right? So that is important. Whatever you do, confidence building is very important. And one more thing which I always tell my students is diversified reading. See, let me tell you again, let me reiterate. Anesthesiology is a very difficult branch. In fact, I find it to be the most difficult in all the branches available in the medicine. And irony is that even a bit of it is not taught during the undergraduation. You suddenly end up or appear for your post-graduation in anesthesiology. And sometimes I find that anesthesiology doesn't have any boundaries. It is a boundaryless branch, you know. You have to master of pharmacology, anatomy, physiology, right? The drug interaction, the toxicology, the allergies, their management, resuscitation, its management, and anything and any time. You look at this COVID period, who were in the maximum demand? The anesthesiologists. Because these guys, if you must have heard that English language, the jack of all trades, master of none. Actually, anesthesiologists proved to be a master of everything. And he works with the economists. And so how you can become a master of everything? That is by collateral reading. You are master of ECG, learn ECG, like a cardiologist do. So that is what's important. So we have gathered knowledge. 3 years we gathered experience. This is the gist of my talk, you know. if in a way I can say. That ultimately what happens, this knowledge and experience, you put it in a hopper. That is the examination mill. And it works for 3 hours. Multiplied by 2, 3, 4 days, whatever, how many papers you have got. And then it will end into, the end product will be either a degree or diploma. So in the hopper goes your knowledge and experience which you have gathered, right? So that is there, that's very important. But because it is a machinery, this examination bill is a machinery, so it works on its own principles. And this process, the way this mill works, depends on 2 very important parameters. One is the memory, means your memory has to be very strong, especially in medical science, because you have to learn so many things, right? They have to be on your fingertips, right? So that is very important. So if you keep on working, day-to-day practice, if you are learning every day something about, then this onslaught on your memory bank inside the brain, right, it starts working. It is there to work. Only you have to make it work. As much as data, you put in and take it out, put in and take it out, the things will become easier. Your memory will get sharpened. And the other thing is, the way you answer, means how you make this mill run, the exam mill, right? So that we will see it now. Always remember that mock practices are very important, means you learn a lot. You gathered a lot of it, lots of education, lots of collateral reading. But if you don't know how to put it in a nutshell so that the examiner is able to understand, right? As if you are playing here and there, but you are not just hitting the bull's eye. So your hard work can become counterproductive throughout 3 years in a short span of few days and hours, what you call as the examination. So keep on practicing. Even still, if you have a 1 week, after that, means before you go to the exam, do some mock practices. 4 or 5 people sit down together, fire questions to each other, right? It will help you out. So at the outset, when you go for theory, first of all, read all the questions. Look at the format of questions. Supposing there are 10 questions, look at the format. Those will be different. And immediately allot the time for each question, right? Time management is very crucial. You don't want to write a lot on one and miss 4 or 5 others, because then your sloppiness will be visible to the examiner. And whenever you are answering a question, because you know, in our science, medical science, it's a big gray areas, means we can never be absolute right. So there are always pros and cons. So in your argument, when you write the examination, your papers, your questions, you have to have certain cons also. That everything is not good. You're describing an instrument, well, it has its own problems also. That shows that, yes, at least you will not do harm by using that. You know when to use it, when not to use it. You know, in medical science, as we age, the aging brings in what is actually not to be done. That is important. And always assign some time at the end of 3 hours so that you can just review your questions. The other very important thing is, because we keep on seeing all the times how the answers come up in the question answer books, the best answers are which are structured. Means you begin with some introduction to the question, and the main body of 2 or 3 or 4 exact paragraphs, and then you conclude it. It's very important. If your structured thing is there, it really makes your question good to look at, to read it, and also to mark it. And whenever you are reading your questions, keep a pen in your hand. Always remember that human brain, whatever activity it does, if that activity goes along with some somatic activity as well, means you are doing something. Like, people develop certain kind of tics. Means they are either shaking hands or something like that. Actually, this is a kind of coupling between what's in the brain and how it is coming out, right? And that tic is actually helping out to draw that information. So if you've got a pen on the hand, then your brain immediately understands that you are serious. And it will do, because you can mark on the questions, and also you can mark something somewhere else as well. That I'll show you just now. And this is one of the most important thing for me. I always explain people that don't actually, the red light and the green light, these are they are not the smart lights. They are simple, straightforward information. Red, stop. Green, move. But the most important one is the middle one, the amber light, the yellow light. Why? Because then that is there, you have to pause and think of the next action. So this light should work always in your mind. When you are reading a question, just pause for a few seconds. Gather yourself up. Gather your information. Draw it from your inner memory banks of the brain with a pen in the hand, so that you are able to answer it properly. The other thing, if you've got a pen in the hand, then immediately you are reading the question, identify, underline the important words in the question that needs to be answered. Like I have written a question here: how mixed venous oxygen assessment can help in goal-directed therapy in intensive care unit. Something to do with hemodynamics, how you want to actually potentiate it so that the patient doesn't get problems. So you underline mixed venous oxygen assessment. You have to write something about it. And also to the goal-directed therapy. And then you have to build up a link between them. That is how you prepare before answering. And always remember, I have seen people just forget the context somewhere when they are answering the question. So context is very important. Value of X can be anything, but we have to understand that in the question, what it means, right? Sometimes people just don't understand and they write here and there, but they don't home in to the real answer. So understanding of context is very important. And always remember that when you open up, when you start answering, like the previous question which I showed, right? Then you actually start with mixed venous oxygen assessment. What happens? It is a kind of introduction that how this acts. What actually is this assessment? What it is telling you? What is the context with the goal direction in a patient who's very sick in intensive care unit? So that has to come up. Again, a very important slide. Let me again tell you, do you know how long it takes an experienced examiner to look at your paper and mark it for 1 or 2 minutes? Just take my words. It's not more than 5 or 6 minutes. You can say, oh, is it so? Yes, he only looks at the intro. Like if you know an English word, supposing, right? Beautiful. Your mind doesn't read the whole word as beautiful. It will just lift one or two words or letters in the beginning, BE. We'll look at the length of the word and how it ends. That's it. That much information is needed to build up the picture of beautiful. The same thing is here. If I read the intro, if I read the conclusion of your answer, I know what you mean. My experience immediately gauges you what you have done. Just I will try to find few important salient points in the main body of the answer, and that's it. That decides beyond 50% or less than 50%. The body must have 2 to 3 or 4 paragraphs according to the content of the question, and always take means these kind of words, which actually tells you that you mean your business. And conclusion is also very important. Finish off with a paragraph, like just you are summing up. So you sum up with whatever it was in the beginning, how it ended on, and ultimately what was your conclusion. So you can actually do that. That goal-directed therapy must target this much of mixed venous oxygenation. And you can build up a decision tree on the basis of that. And you can have other parameters that has to be actually looked into and changed so that you can attain what you actually needed. Now, just to give you another question, which we placed recently in our mock-up exams. It's a very recent phenomenon that's occurring. What's the mechanism of hypoxia and COVID-19 disease? See, 4 marks. Discuss the oxygen therapy in these patients, 6 marks. So it means the examiner wants you have to be very elaborate in oxygen therapy. But if you are just accurate with the mechanism of hypoxia, that is there. You don't want to be very exact, put up all the description and all that. And many people try to do that. And what happened? They forgot oxygenation therapy. They only just mentioned 1 or 2 lines. So that actually tipped the scale of balance, and you may lose marks. So draw some figures. For second part, give everything. Oxygenation algorithm from simple to complex. Don't forget ECMO. It has been used. Don't forget lung transplantation. It has been done. And do not forget to write other therapies along with oxygen therapy, whatever the existing ICMR guidelines are there. And in conclusion, oxygen therapy, home or hospital, monitoring by pulse oximetry, all these things, if goes in, that's it. We'll be happy. So that is how to answer the question. And few nuances. Well, always try to be simple. But it should not be so simple that you forget and lose the context, as the boy Peter lost it here. Your education, the way you learn how to answer the question, will take away the self-doubt, because it creeps in very fast when you are sitting on an examination. There may be some thought blocks as well. But let me give you a tip, because thought block can occur at any point of time. You may get stuck up at any question. So, but you have already read the question paper in the beginning, so your mind starts working on that. You might be answering goal-directed therapy with mixed oxygen saturation, but you have also read the COVID. So your mind suddenly, few points for that question flashes in. Now, always remember these flashes. Keep a tag of them, right? If they suddenly come into your mind, you immediately on the back of your answer sheet, you put question number this and those points, because you may forget them again. So you have got good points on which to elaborate. That's the best way to actually take care of thought blocks. It's a common thing, it happens to anybody. 20 years back means I was speaking on some platform and suddenly I had a thought block. Means I have to stop, take some water in, and then I have to begin with a different way to tackle that problem. So it happens. Don't fear it. And another very important thing is try to attempt question in that order as given in the question paper. Because the examiners, because they don't like means to turn your papers too often, back and forth, and then they will say, oh, this person has done what? So try to do that. And also, don't try to be over-ambitious, that you know a lot about something and you write a lot on that. What's the fun? You may commit mistake, Straight answers, give a straight answer. That's it. And always remember, when you write, leave the margins. On the left side, there will be a margin, but on the right also leave a margin. Leave a margin at the bottom of the page as well. Don't write up to the last, means where the page ends and the table begins. Don't go up to that point. Stay around 1 inch above. You may have many copies because it is like a framing of your question. It makes us more beautiful. And then handwriting. See, when I was a consultant in United Kingdom, one of my ODAs, when I used to write, he used to shake the paper like this. I said, what are you doing? He said, trying to understand what you have written, Prabhat. Why? This is a doctor's handwriting, you see. You have to shake it up, then it will form the words. Well, that is how handwriting evolves, in the medical profession. Because we are too much procedure-oriented, looking at the patient and all that, right? So somehow handwriting takes a back seat. We are not a kind of a person who's living by the writing. But those who have good handwriting, right, which is at least you can read it properly, they always get 1 or 2 extra marks. Always remember that. So whenever you are writing, make small sentences, full stops, commas. They are important. Use bullets. Bulleted text always looks good, and it also shows that you are not cluttered and you know what you are doing, right? And always remember, important point, important diagnosis, which is most common, right? That must come as a first place. And avoid writing controversial things, because you are only appearing in an exam for MD. You are not writing a paper for Lancet. So don't give too much of controversial points, right? So you are just wasting your time. Only 1 or 2 concepts per paragraph, not too many lines in a paragraph. And don't try to beautify what you have written. A good handwriting with bullets and few colors, that is enough. Avoid too many underlines. I got once to see one paper, right? And where means I think I could count words that were without underline. The rest was all underlined. So what's the fun? You have lost actually giving into what is important, because everything is underlined. And don't use more than 3 colors in a page. More colors, don't try to build a peacock or a rainbow. No, rainbow looks good in the sky, not on the paper. And also be consistent in the use of colors. Means, supposing if you are putting your headline with red color, then use the same color palette, Don't try to change. it too often, it becomes irritating. And one more very important thing you see in medical science, because we use so many abbreviations. So always use universal abbreviations. Don't create your own abbreviations. Very important, because then you have not given a key of your own abbreviations anywhere on that paper sheet. So why you want the examiner to really rake his brain, go to the Google and find no answer? Here's what this guy has done. Nah. So you have to build up your impression. And also because you will find the questions have guidelines embedded in them. You look at them, define, describe, discuss. You should know how to answer that. And medical science also use appropriate diagrams, flowcharts, table, illustrations, because picture can give you, means it can give information what the words can't, right? So that is important. Like a nurse in Sri Lanka, one of the hospitals I visited, you see, I saw their NPO, the way they explained, and when they told us that, look here, when we started drawing these kind of pictures, the compliance was 100%. So that's the power of picture. So quickly we go to the practical examples, case presentations you will have. So that was theory. Nowadays, theory also means you have to pass your theory. So these are few things if you take care of, you will be able to answer well and score more than 50% marks. That's what's required. Now to the practical examination for 5-10 minutes. The difference between practical exam and the theory exam is that in theory exam, you need to give your lots of information, right? And the information that is there, like ECMO, you may not be using it, or you may not be able to use it in your lifetime. But if you give that information, it actually, you may get more marks. But in practical examination, it's just the reverse. You don't tell ECMO or something like that, but if you falter in oxygen therapy with mask, with nasal cannula, how much you are going to get it, means the basics, then it will be a real hard walk for you through the practical exam, you see, because that is the difference. Means the basics you have to know. You may falter in something which is really difficult or it's a recent advance or whatever. No. That is the difference. You get a long case and the short cases. Long cases means the history and everything is more important. In short cases, it usually begins with the diagnosis, right? And the management. That is the difference, you know it. But few points which I think are very important, that first of all, when you approach the patient, then know your patient. Talk to him. Talk to the patient. What's he doing? What is his profession? All these things. Because that may give you, look at the hands and all that. And then know your audience. When you are looking at the patient, then if the relatives are allowed. And then when you have prepared your paper and you present it to the examiners, now the audience is the examiner. So level of understanding, intelligence, everything is changing. So you have to be ready for that. And know the situation. Situation is, well, the examiner, right? Supposing you have not done well in the long case. Now the situation is slightly difficult for you in the short cases. You imagine that, well, I have to perform it now. The situation has changed. But I don't want to say that if you have done a long case very good, then you just mess up with short cases. No, that's not like that. And of course, practice. You have been practicing for 3 years. Every day you are looking at patients, taking histories and all that, and putting them up in front of your consultants every day, right? So practice, don't forget it. It is the examination every day. Examination is not a great day in the life of a medical student. Always remember that. So always remember, there is a template for oral presentation, which must have these things. You know, chief complaints, history of present illness, review of systems, past medical history, very important. Past surgical history, very important, right? Patient may suddenly tell you that, well, doctor, I went for this hernia and then I became unconscious, stayed in ICU for some time. Well, it's a very relevant history. It can give you many ideas into the patient, what was happening, why it happened. It will make you wiser. And when you tell this to the examiner will immediately say, oh, he may not be a good doctor, but he's a very safe doctor. Right? So that is how you just keep on getting brownie points for yourself. People forget allergies and medications. Always remember, we are using so many drugs which have never been used, like propofol, or lipid-based, egg emulsion-based, etomidate, right? Nobody will just go to the counter and ask for propofol and etomidate, right? So these are drugs which you are going to use probably for the first time and maybe for the last time on that patient. You have to know about the allergies. Smoking, alcohol, social and work history, everything tells you about that. And then you give up to physical exams and that. So be organized. Put up a template for yourself and follow the same template all the times. And I always tell, this is my favorite slide for practical tips. Tell a story. And in the middle of that is your patient. So you weave a nice story. And remember, the lady medical students, they are very good in telling the stories, right? But when a male or a gents medical student tells the story, then he immediately stands out. But it has to be a truthful story, a well-organized story, right? With a beginning, middle part, and the end. And always remember, right? You start with a strong opening sentence. Sir, I'm presenting Mr. So-and-so. Always treat the patient as a person. Never treat a patient as a patient. He is still a human being. And if you do well on that, you will send him home as a human being. So always remember, start with a strong opening sentence, right? That, well, I'm presenting Mr. So-and-so, right? Or if you are telling in Hindi, sir, मैं आपको जो ये Mr. So-and-so बता रहे हैं, या श्रीमान ये बता रहे हैं, इनके बारे में मैं बता रहा हूं. See, it immediately clicks in the mind of the examiner that, well, he is humane. That is what we need. Present the patient and the illness. Never forget the patient. Present in the logical sequence, right? And all the positives and the negatives. And once you have done it, then summarize the case. People immediately sum up. After history, they immediately go to the lab investigations and other investigations, and then suddenly management. No, that is not the way. Once you have finished telling the story about the history, you sum up. You can say, sir, now I conclude as, put up the positive points, that these are important points. The examiner will suddenly, if he was talking to his colleague or eating some kaju and kishmish or drinking some tea, he will immediately sit straight. Oh, this boy is making a conclusion. Very, very interesting. And then you will say that after this, my differential could be this, 4 or 5 diseases. And then I will go to all the laboratory tests and all that, so that I can prove my hypothesis of differential diagnosis. Oh, examiner suddenly becomes very happy. He may not show on the face, always remember, but he'll be very happy inside. So after differential diagnosis, you go to your investigations, and again, you sum up. Tell the gist of the history, and the investigations, and ultimately, what's your differential diagnosis and which disease or which thing stands first. Improve your presentation, be enthusiastic, use an audible way of speaking, right? That is important. We want to look in your eyes that you are enthusiastic, and try not to read your presentation, what you have written on your 3 or 4 pages in which you are writing the history of the patient. You just memorize. That's why memory is very. If you are looking in the eyes of the examiner and presenting that, it is always very good. It shows that, well, you are sincere, you are honest, you have done a hard work throughout your 3 years. That window opens, right? And at the end of the examination, you see, you may ask your mentors or the internal examiner that, sir, can we have the feedback? Yes, every examiner, they will not tell you whether you failed or passed. That comes indirectly in the evening. Somebody raises their hand, yes, you have passed. That these are our peculiar ways of telling people that you have passed. But, right, they can give you feedback and listen to that feedback. Supposing you have to stay for next 6 months, that feedback will help you out. In 6 months, oh, there's nothing like past fail. More tips include only the most essential facts, right? Be ready to answer any question about all aspects of your patient. That is very important. And be honest. If you have not done something, don't say you have seen. Supposing you forgot to put hands on the abdomen to palpate the liver, in the case of mitral stenosis, say, sir, I forgot. Oh, okay, no problems, man. Learn it. Your honesty will fetch you marks. Keep your presentation lively. Keep in mind the limitation of your listener. See, examiner, of course, means he's not there for fun. He has to listen all the humbug. And beware of jumping back and forth. The same way that when you are writing your paper, then just don't go out from one, that you start with the last question first. That is okay. We'll say, okay, it is going from 10, 9, 8, 7, 6, 5. No, 10, 1, 7, 8, 5, 4. Oh, horrible. After all, it is an exam. So, well, your abilities will be different, but the examination will, of course, be the same. Otherwise, people will go to the court. They say, oh, for me, the question was different. For him, the question was different. For the written exam, I'm saying, not for those exams in which batches of people come in to take multiple choice questions, because there they keep on changing. So it may be unfair for some, but always remember, examiners don't want to make it like that. So, and always remember one more thing, the examinations are really formidable, even to a person who is very knowledgeable, prepared a lot, because we have seen that. Because on that day, somehow he has not performed well. So, no problems. Come after 6 months. It's not a big deal, right? Why? Because the greatest fool can ask the nastiest question, which nobody can answer at that point of time. He may answer after 6 months, but not at that point of time. Thank you very much for the kind attention, and I say good wishes to all the exam going students that you do well. Thank you very much. Over to you, Sandeep.
Thank you, sir. As usual, for last so many years, we are hearing you with advices, and again, it's rightly impacted what we should do in our exams. And the points are well taken, not only practical, but also in theory exam, how to write. Now we will invite the questions. The residents are also in the Zoom group. As the PGI residents are in this Zoom group, they can ask directly, or you can write in the chat box.
They can write in the chat box, I think.
Because in We also inviting questions from our listener from the YouTube. Presently, I think 150 are there. So, any questions? People are saying very good presentation. Although there is a time delay, so the voice was clear because I was also watching on YouTube and simultaneously on the Zoom. So it was perfect, but there can be net problem somewhere at the receptor end. So if you don't have a good net, then it will be more so. So do we have questions? Anybody can ask any question in the chat box. Because if you will not ask, then
I'll be happy. I'll be happy.
कोई छोटा क्वेश्चन नहीं, कोई गलत क्वेश्चन नहीं. Any question, anybody can ask. जब तक आप लोग क्वेश्चन नहीं पूछ रहे हैं, चलो मैं शुरू करता हूं कि sir, it has been seen that people, if they have got a new question and they don't know the answer, they start writing anything that they know about the topic. Means if they have specifically asked what is the thyroid anatomy, but people, if they don't know that like a brachial plexus anatomy, they try to start writing whatever they know about that topic. So we should be very specific because there are two type of questions nowadays. In MD there are three more main questions. They can have a part, but in DNB they have part A and B, and they have more things to write. Like around they have 10 questions in a paper. So what is your say that if I don't know any question, should I write anything or what I should do?
Well, the important thing, see, this I think I have covered in my first part of the talk, that if you don't know anything about that, right, then you just leave it like that. Never try to write wrong things. Never try to just beat around the bush. That is the commonest mistake people do. Even if you have answered well in 50% of the questions, you may get, right, at least 30 or 40% of marks in those, right? So that is there. But you are also making an impression because there may be 3 or 4 papers. So you are making an impression on the examiner that, well, this person knows a lot. And ultimately, it is not. You are judged not on a single paper or something like that. They have to be accumulated, and then points come up. Well, if you don't know many of the things, right, then I think it is better you wait for 6 months, right, and you know how you have to prepare more. That is what's important. Because you see, once you go to the patient, right, of a thyroid, and instead of looking at the thyroid, you start palpating the abdomen. I think that is the worst scenario. So don't do that. The same thing is there. In medical science, you are just looking at what is what.
But we have like one suggestion that one student has said they are paying for the super specialty NEET exam, and these tips will help them for super specialty exam. Another question that is, what about OSCE practical pattern? Because DNB exam has OSCE pattern in practical. So they are asking, what is your say on DNB practical OSCE pattern?
Well, actually, DNB, I like the DNB way of examination, to tell you very frankly, because they have made everything very objective and all. So OSCE pattern means, I fully agree to that, means that is the way any practical examination has to be done. You know, it's not just you sit across a table and just there has to be stations, and there are properly formatted pick questions for that station, and then you actually move around that. But somehow our MD course, MD curriculum has kept all these things, means they have never been addressed in MD style. The reason is that, well, probably I don't know exactly the reason, but the thing is that MD examination pattern now, it should go to the DNB pattern, where there are centers in which certain people are coming around, right? So that is important. There you can have many examiners, you can have many stations, you have formatted questions, because if you write a question, then actually the examiner has to know, actually this question, supposing I have formatted, then I have to give an idea, right, for the person who will man that station on that day, that what actually I intend for that examiner to bring out from that candidate. That is very important. In fact, MD curriculum in our country has not kept pace with this kind of pattern. What do you
They are asking for the tips for OSCE.
for that, I have to go again and put up a new presentation. Over to you, Sandeep.
Sir, a student is asking that tips for the OSCE, DNB OSCE practical exams.
For that, you see, I have to take another class. Well, see, the principle of all this stays the same. Principle which I have told you, they just remain the same, whatever the pattern is. Okay?
Yes, sir. So just to give you an overview, that MD exam you are getting 2 long case, 1 long case and 2 short cases for practical. But in DNB practical exam for OSCE pattern you are given 4 cases. All 4 cases is not divided in long and short, and that to be discussed on 4 different tables in 1 hour. So time is given 1 hour for 4 cases, and when you go and like first table you will be assessed for the history taking, second table you will be assessed for the examination, and third table you will be assessed for the anesthetic management. So anesthetic management they can ask for 2 tables. So after that, when you go like there are 5 tables for the after cases, 5 tables for the assessment of the Viva OC exam. Like one of the equipment that you same get in the MD exam. One of these is the CPR. They want to assess your
See, Sandeep, I told everything in my lecture. If they are listening on it, then it is actually, we see the same thing is happening, right? If you are making tables, the point is that there it has to be very clear that, well, this is the area has to be covered on this by this examiner. That's it. That's the difference. There is no other difference. So unnecessarily, students should not get clamored. There was the difference here, was there? No, you gather the knowledge. You try to represent your thing like a story. You see? So that is there. As I said, you keep on summing up. Here, what happens? Summing up means once you have summed up at one table, you go over to the other table. So things are the same. Pattern is the same. That understanding has to come in the minds of the student. See, that's what NEET has done, means, or those handbooks have done. That you want everything cooked up for you. No. See, that's what Pink Floyd has said, that we don't want a brick in the wall. You start thinking up. More knowledge, And the way you just spread it across, it may be 2 tables, it may be 4 tables, it may be 6 tables. And many a time in DNB, what they do, that they say that don't go to the patient, just give scenarios. Now, the con of this pattern is the scenario. I want to see how the person will do this kind of assessment on the patient. Is it wrong or right? I want to see how he is doing the Allen's test. So that kind of thing, you see. So there are so many things on both the sides. But the first thing is that how you go ahead. You spread it across the tables or on the same table. The pattern remains the same. Your assessment, your judgment, your evaluation, and how you actually frame the answer, that remains the same. Because examiner is a person. It is not a robot. It doesn't go by algorithm.
Yes. So, as sir rightly said, I think most of things will be repetition what he said in his lecture, and focus on the key points. And if you amalgate these points, then it will be a best in theory and practical, because you don't want to be stuck at 50%. Nowadays, the MD also giving you number. Earlier it was fail pass, now the percentage is also there. So you can improve your percentage, because that will be once in a lifetime. Once you make it like 50%, it's just 50%. Even some they are giving gold medal in the department, depend on the who is the best. Like in MD, SGPGI, we have 16 students. So who will be number one? It's you can be number one. Anybody can be number one if you present yourself in a way that sir has discussed. So if we have most of the students said that in question they are very benefited with your views, but they don't have any separate questions till now.
Okay, thank you. Time
I
is up.
think
We can go
time
to
is
the
up.
other one.
So thank you, sir. Thank you so much, and for
Can
your
I leave,
time.
Sandeep? Can I leave?
Sir, thank you so much, sir. Please.
Okay.
Thank you so much. So we are moving to next session, that is on pre-anesthetic checkup and optimization. This is to be taken by Dr. Professor Anil Kumar Verma, and Professor Anil Kumar Verma is professor in Department of Anesthesiology at GSVML College, Kanpur. He is a very good friend of mine, and nowadays, even today, he is not fine, but he just sent me his recording, and it's good that in COVID time we have learned speakers, those who are even not present with us, but their voice and their their uh, their understanding of the subject and their command of the subject will help us. So pre-anesthetic checkup will be taken care by Dr. Ankur Verma, and we have Dr. Aruna Bharti as a chairperson for this session. Dr. Aruna Bharti is a additional professor in Department of Anesthesia at SGPGI. So I am going to start the lecture. It is a video recorded, voice recording with the slides. So if we have any question, we will take later on after the completion of the session. Dr. Anil Verma will be there to take your questions. So we are starting the lecture. Thank you.
Good afternoon, everyone. So I'm Professor Anil Verma from Kanpur Medical College. I convey my thanks to the organizing team who has given me the opportunity to open up this refresh course. And I'm here with the pre-anesthetic checkup. So pre-anesthetic checkup is itself is an opening of any patients who are going to have received the anesthesia for the surgeries. So why this pre-anesthetic checkup is so much important? Because the overall outcome of any patient in perioperative period depends on what the information anesthesiologist will have. So the pre-anesthetic checkup is nothing but a clinical assessment of a patient before surgery to gather as much as information which can help for the perioperative management. Whereas the perioperative management is the overall management of the patient before surgery, during surgery, after surgery. So pre-operative assessment is a clinical assessment of a patient before surgery. There was one analysis done by the Australian Incident Monitoring System, where they have seen that almost around 11.6% is the incidence of inadequate and incorrect preoperative assessment, out of which the 3.1% adverse incidents are due to the inadequate and incorrect preoperative assessment. Among these 3.1% of adverse incident, more than half are preventable and 21% are possibly preventable. Only the 5% of these 3.1% is unpreventable. So this is a big number where the poor and incorrect pre-anesthetic assessment leads to the adverse incidents, which can be prevented by adequate knowledge and proper pre-anesthetic checkup. So what are the goals of the pre-anesthetic checkup? It is to create a rapport between the patient and the family member, allay the anxiety of the patient as well as the family members, and it also reduces the overall morbidity, reduces the unanticipated ICU stays, overall hospital stays, the cost of the treatment, and so on. So there is a terms which is called pre-anesthesia consultation and pre-anesthesia assessment. Pre-anesthesia assessment is an establishment of a health status at a particular point of time, which is an integrated component of the pre-anesthesia consultation. So in pre-anesthesia consultation, pre-anesthetic assessment is there, and there is also the also preparing of a plan in the perioperative period. There is a preparation of a plan for the post-operative analgesia. There is that also allows a discussion with the patient and the guardian, and also allows to obtain an informed consent from the guardian as well as the patient. So this is overall preoperative consultation. So what is the prerequisite where this pre-anesthetic checkup is being done? So for this pre-anesthetic checkup, we should have an adequate room where the appropriate privacy for the examination of the patient and appropriate arrangement for the disinfectant and washing facility with adequate number of equipments like weighing scale, blood pressure instrument, SpO2 measurement, the height scale, that should be available. Yeah. So when we go for the pre-anesthetic checkup, it not only gives an assessment of the clinical condition of that particular point of time of the patient, but it also gives adequate time for the optimization of the patient before surgery, before anesthesia, adequate and creation of an adequate plan for the pain management. And this is especially important for the patients who have comorbidity and who need to undergo for the major surgeries. So, but there are certain conditions where this pre-anesthetic checkup is not possible, especially in the emergency surgery, labor patient, the patients who are admitted in ICU and needs an emergency exploration. So there, this pre-anesthetic checkup is not possible. So every assessment or this pre-anesthetic checkup should have particular guidelines. Among these guidelines, the first point is to identification as well as introduction of consultant to the patient. Then confirmation of the patient identity, what surgical anesthesia procedure is to be given to the patient, what is the site of the procedure, and who is the procedurist. Adequate medical history is also the component of the guidelines for the pre-anesthetic conditions. Adequate medical records to be assessed, proper examination of the patient, all medication which the patient is already taking should be checked. Review all the past investigation and the present investigation, review all the previous anesthesia reports or any happening which happened in the previous anesthesia If there is any need for any specialized consultation, that has to be taken, and for this, the anesthesiologist himself is responsible to decide about the specialized consultation. So, for the appropriate level of care, as per the proposed procedure and certain comorbidity, there should be certain facilities should also be available for the treatment and the monitoring of the patient. There must be appropriate staffing of the patient in the pre-anesthetic as well as in the post-operative care facilities. Appropriate equipments should be available in peri-operative facilities. Appropriate information to the patient guardian should be given about the anesthesia, sedation, pain management, any sort of post-operative or potential complication, any sort of risk with any procedure which we are going to do with the patient. So there should be a proper appropriate information. The obtaining informed consent regarding the type of anesthesia, any invasive procedure which you are going to do, any blood of blood products that you will transfuse, and about the pain management also. We can also prescribe certain additional medications or may change the medication which the patient is already taking, and certain medication which may also need to stop before surgery. That is also the part of the pre-anesthetic consultation act. And particularly in case of a daycare procedure, there the escort should be available, and he should be properly informed about the procedure and the patient's post-operative the procedure what you are going to do, and what would the post-operative condition, and how when the patient can be taken back to the home. So all the information regarding patient and the procedure should be given to the attendant also. There is also instruction of fasting, which is also the part of the pre-anesthetic advice. So when we examine any patient and take an appropriate history, so we do the proper pre-anesthetic checkup. This is also our duty to give an idea to the attendant as well as patient what could be the risk. And this risk are mainly based on the grade of surgery and also based on the American Society of Anesthesiology physical status. On the anesthesia basis, I will on surgery basis. So if we talk about the grading of the surgery, it could be minor, intermediate, and major. All the minor surgery, which are the superficial surgeries like excising the skin lesions, intermediate surgery, which are like tonsillectomy, excision of the varicose veins, and any inguinal hernia repair, and arthroscopy procedure. But the major surgery can be do the thoracotomy, the laparotomies, the head and neck surgery, the thyroidectomy, the hysterectomies, and vascular surgery, above inguinal vascular surgeries. These are called to the major surgery. Now, the another method to give an idea about the post-operative risk as well as morbidity, that is the American Society of Anesthesiology physical status. This is developed in 1941 by Mayer Sackler, but the disadvantage of this classification is that there is no consideration of the type of surgery and no diagnostic studies are taken into consideration. So now, so another classification was developed, that is Johns Hopkins risk classification system, but this classification was mainly focused on the surgical risk. So this is a classification every one of you know, and the E is added when the surgery is emergency, and ASA classes, which is a perfect donor. So when we do the pre-anesthetic checkup, definitely we take the proper history of the patient. We track all the previous records, medical records, the drug history, everything into consideration. We also examine the patient. We also go for the certain, we also prescribe certain investigations pre-operatively. But there, so what investigation could be advised to what type of patient? So there, they try to just simplify those investigations and try to limit the prescription of investigation according to the type of surgery and the ESA status. So in the minor surgery, in ESA 1 and ESA 2, mostly there is no need of any sort of investigation because it's a minor surgery, simply superficial surgery, so no need of certain blood investigations. But in the ESA 3 and ESA 4, the ECG may be considered in a particular cases where the patient is showing any history of cardiac involvement or any renal involvement or metabolic involvement or something like that. So in that case, ECG may be done, but if there are certain guidelines for the ECG, which we'll discuss later. In intermediate sort of surgeries, the full blood count hemostasis that is not required for the ESA 1 and 2, but for the ESA 3 and 4, the people with the cardiovascular renal disease, they may need the full blood count and hemostasis if the people are taking any anticoagulants and any requirement of modification of a regime. In that case, we need to go check for the coagulation status of the patient, and in certain conditions, we may need to switch over, stop the previous medication and switch over to another medication. So in that case, we need to follow the coagulation status of the patient. There are certain disease system developments like liver disorders and renal disorder where the coagulation status may be affected in that case also. I mean, coagulation status. In ASN 1 and 2, the kidney function is all done when there is any sign, history or sign or symptom of acute kidney injury. ECG, again, there are certain guidelines whether ECG can be done. ECG is not routinely prescribed to any patient without any symptom. There is a certain reason when we prescribe the ECG. So similarly, in the major complex surgeries, mostly the full blood count, the hemostasis, specifically in case where the oral hypoglycemia, oral anticoagulants are being given, and we may need to the change in regime or modification of regime. We may require to switch over to the parental regime. Then we need to go for checking the coagulation status, or maybe any organ system which is affected with the coagulation status. And in that case, we also need to assess the hemostasis of the patient. Now, the kidney function, definitely, if there is any sign or symptom or any history related to the acute kidney injury, go for the renal function assessment. ECG, yes, being done. Lung function test. Whenever there is a lung function test, we should always take an opinion of the pulmonologist or senior anesthesiologist regarding this lung function test. Lung function test. Okay, so this is an exhaustive chart where different investigations are being shown, and the need of those investigations according to the estimated blood loss, according to the age, according to the various medical condition. And if you see there, here we can see the estimated blood loss, if it is more than 500, hematocrit is required. And simultaneously, the type and the screen and the type and cross match needs to be done. But when the 50 to 500 ml is the total expected blood loss, hematocrit and screening is enough. There is no need for the cross matching immediately. If it is required, later it can be done. But if the blood loss is expected to be less than 50 ml, then there is nothing to worry. No investigation as such is required. Only the chest X-ray depends on the clinical condition of the patient. So the patient's age, if the patient age is more than 50 years, though it is being said that mostly we can go for the ECG, but ECG is mostly done after the age of 65 years, unless until the patient is having any previous cardiac condition or any sudden change in the cardiac condition, sign or symptoms. So there are certain medical conditions like cardiovascular condition. Hematocrit is definitely, we go for the hematocrit. Certain hematological conditions, hematocrit is done. In hepatic disease, hepatic disease, malignancy, metastatic female, pulmonary disease, radiation and renal disease, that hematocrit is being done. But for the cardiovascular disease, the important investigation which may be required, that is the chemical patient. In chemical patient, there are 7 investigations comes into picture, that is sodium, potassium chloride, bicarbonate, and glucose, urea, and creatinine. But the chemical electrolytes in this category, the 4 investigations are 4 investigations, 4 parameters are red, and this is especially done in the pulmonary disease. The chemical electrolyte where sodium, potassium chloride, and bicarbonates are being measured. Whereas the chemical basics, where the sodium, potassium chloride, bicarbonate, glucose, urea, and creatinine is being measured, it is done and all the cardiac patient, the renal patient, the diabetic patient, and also in the neurological patients. In hematological patient, the hematocrit is being done in every patient, but in case of anemia, we just go for the type and screening and cross matching done. But for the bleeding disorder, we also go for the platelet function test and the PTT, EMPT, and INR also. In polycythemia, simply hematocrit is sufficient. In sickle cell anemia, simply hematocrit is sufficient. Hematocrit is sufficient. So if we see what are the guidelines given for the chest X-ray is not routinely indicated for each and every patient without any indications. It is needed when particularly we are going to perform any surgery, into the thorax over the lung or the heart, or if the patient shows any change in the symptom or any appearance of the new symptoms related to the heart and pulmonary system, like any chest pain, any cough exacerbation, any breathlessness, any orthopnea, any paroxysmal nocturnal dyspnea, any ankle edema, or decrease in the exercise tolerance. In that way, we can go for the chest X-ray. Similarly, if you talk about the electrocardiogram, in all male and females, when they are more than 50 years of age, we can go for the ECG, electrocardiogram. But in the diabetic patient, if the ECG is being done in last 3 months and there is no abnormality found, then there is no need for repeating the ECG. But if any abnormality found, this is time reduced up to 1 month. So with abnormal ECG, it should have been done within 1 month. It is not going to repeat the ECG. But for the non-diabetic patient, this is time extends 6 months to 1 year. So this is the chart by which we can find out what investigations are definitely required for particular surgeries, particular blood loss, particular medical conditions. So there are other than these investigations, there are certain special investigations which are required, like required. But for all these investigations, when we send any investigation, we should always consider the medication which the patients is already taking. So pregnancy test is specifically done in all childbearing age, but this test to be done by with female consent and it should be documented. Sickle cell trait test is recommended only if there is any family history. Hemoglobin A1C is done only in the diabetic patient, non-diabetic patient. It should be done always fresh, and if there is no reading in last 3 months. No recording in last 3 months. Urine test is not routinely required. It never affects the anesthesia management, only if it is done in case of a urinary tract infection, otherwise not. So in pre-anesthetic checkup, we also advise fasting guidelines for the patient, for all patients who may either have regional anesthesia, sedation, and the general anesthesia. And the main motive of this fasting guidelines is to prevent regurgitation and aspirations. So fasting more than 6 hours has no benefit, rather have a deleterious metabolic effect and impact on patient well-being. Even volume up to 200 ml of carbohydrate rich can be given just to post surgeries. So what are the clear liquids? So there, the clear liquids are the liquids through which we can see across the liquid. So black coffee, clear tea, and Pedialyte are considered, but okay, fine. There are certain carbonated beverages. They are also clear liquid, but here due to the carbonation of these beverages that can cause reflux, so they are not considered good as a clear liquid. There is universal formula for all ages. So 2 hours fasting for the clear liquid, 4 hours for the breast milk and formula food, 6 hours for the semi-solid and solid, and 8 hours for the fatty food. But if you go for the specifically for as per age, for the adult solid meal for 6 hours and clear liquid for 2 hours, whereas the children above the 6 months are for solid meal, breast milk, and formula feed up to 6 hours and clear foods for 2 hours. This is for the children above 6 months. But for the less than 6 months, the formula feed for 4 hours, the breast milk for 3 hours, and clear liquid for 2 hours fasting is required. So we have already examined the patient. We have sent the investigation for the patient. There are certain many of the patients with particular comorbidities, the patient are already on certain medications. So we should have a knowledge about these medications, what medication should be continued, what should be stopped. So there is a protocol for the medication which needs to be taken at the day of surgery. All the cardiac medication, the perioperative beta blockers, continued medical and like clonidine and all anti-arrhythmic. But there are certain exceptions like diuretics, ACE inhibitors, angiotensin receptor blocker, and calcium channel blocker should be stopped. There are certain anti-reflux medicine like omeprazole and ranitidine should be given. All seizure medication should be continued. The psychiatric medication like benzodiazepine, antipsychotic, and antidepressant should be continued. The bronchodilators, if given to to any patient like inhalational steroids or parenteral steroids given to any patient, that should be continued. In steroids, specifically if it is given for more than 6 milligram for more 6 milligram a day for more than 6 months, and it is to be continued. CPAP, if it is given, advised or prescribed to any patient, specifically for the obstructive sleep apnea syndrome, obstructive sleep apnea patient, and CPAP should be continued in perioperative period. Oral contraceptive should be continued unless until it is stopped due to the high risk of weekend thrombosis. So levothyroxine, HIV medication, all pain medication can be continued except NSAIDs and aspirin. Acetaminophen and opioids to be continued. Rest all NSAIDs and aspirin should be stopped. So there are protocols for medication that should not be taken on the morning of surgery, specifically diuretics, the potassium supplements and vitamins, and diabetic medication, specifically the oral hypoglycemia, and the bolus insulin should also be stopped. Yes, bolus insulin can be given half of the daily doses night before of the surgery, because later we are going to the patient is going to be fasting till surgeries. What are the medications which need to be avoided in perioperative period, specifically the perioperative anticoagulation? All perioperative anticoagulation, the NSAIDs, like short-acting NSAIDs should be stopped a day before surgery. That is diclofenac, ibuprofen, incarnitine, ketoprofen. Where the mid-acting agents, that should be stopped at least 3 days before surgery. That is naproxen, salindic, and long-acting drugs should be stopped at least 10 days before surgery, like peroxicam. The COX-2 inhibitors should be stopped at least 2 days before surgery because of high risk of nephrotoxicity and the cardiac events. All the antiplatelet agents like clopidogrel, ticagrelor, and prasugrel should be stopped. Clopidogrel and ticagrelor should be stopped at least 5 days before surgery if there is no such contraindication, and prasugrel should be stopped at least 7 days before surgery if there is no contraindication. Aspirin should be stopped at least 5 days before surgery if there is no contraindication. Consider continuing aspirin if there is a high risk for the thrombosis, specifically in case of a stroke and myocardial infarction. And the minor procedure like dental, dermatologic, and cataract surgery, their aspirin can be continued. But for the endoscopic procedure, specifically where the polyp is suspected, then aspirin need to be stopped. Though it is a minor procedure, but still the aspirin need to be stopped because we are going to enter into the cavity where we may miss the blood. Other antiplatelet agents like cilostazol, ticlopidine, and aspirin and extended release dipyridamole should be stopped from 3 to 7 days. Warfarin should be stopped at least 5 days before surgery, and their bridging protocol should be followed while stopping the warfarin, and it should be restart after 12 hours once the procedure is done with the surgeon's prescription. Similarly, the dipyridamole should also be stopped if the creatinine, it depends on the creatinine clearance. If it is more than 50 mL per minute, then it stopped 2 days before surgery. If it is less than 50 mL per minute, then it should be stopped at least 5 days before surgery. And as soon as the surgical procedure has been done, and can be started after 24 hours. 24 hours with the discretion of the surgeon, and if there is a high chance of the bleeding, then it can be started after 72 hours. And similarly with the rivaroxaban also. The thromboembolism risk patients, here the estrogen replacement of birth control pills are being given, that should be stopped at least a month before. So diabetes mellitus, preoperative diabetes management, oral hypoglycemic should be stopped because there is a nil by patient's is nil by mouth from the day of surgery. So the oral hypoglycemic should be stopped. Metformin should be stopped at least 24 hours before surgery. Antihypertensive, specifically the diuretics, the calcium channel blocker, the ACE inhibitor, the angiotensin receptor blocker should be stopped at least 12 hours before surgery because they may lead to uncontrolled hypertension during anesthesia intraoperative. All the drugs related to the Parkinson's, that is MAO inhibitor, should be tapered off 2 to 3 weeks before surgery. So this is modifying rheumatoid drugs and TNF agents stopping before orthopedic surgery due to a high risk of infections, and they should be stopped 1 to 2 weeks before surgery, specifically before orthopedic surgery, and should be started at least 1 to 2 after surgery. All the herbal preparations should be stopped. It is better to stop all the herbal preparation because in most of the herbal preparation, either they interact with the anesthetic medications, or many times they themselves have certain complications like ginkgo biloba, ginseng, garlic, ginger, green tea, everything. They affect the hemostasis, and change of word that interacts with the alpha-interleukin or the sedative agents and local anesthetic, and also interacts with the calcium channel blocker. They should be stopped at least 5 days before surgery. So the Valerian officinalis used for the insomnia, abrupt stopping of this drug may cause benzodiazepine-like withdrawal system, so it should be gradually tapered, and all herbal medicine should be stopped at least 2 weeks before. The postponement of the surgery is not recommended, except if we are not going to do any closed compartment like neurosurgeries. The psychotropic drugs, antidepressants are most commonly used drugs, and patients taking selective serotonin reuptake inhibitors have very high incidence of hospital mortality and readmission rates. The reason is discussed later. The tricyclic antidepressant that reduces the presynaptic uptake of norepinephrine and serotonin, blocking postsynaptic cholinergic, histaminergic, and alpha-1 adrenergic, and just because of this, that causes the increased sensitivity of symptomatic drug, and hypertensive crisis may be there. And there is a varying effect, variable effect, like anticholinergic symptoms are there. There are certain sedation and cardiac arrhythmias are there. If they are suddenly stopped, then again the cholinergic symptoms precipitates the cardiac arrhythmia, certain movement disorders, and sometimes relapse occurs 5 times more potent than before. So when there is SSRIs are being given, then try to avoid direct or indirect symptomatic drugs and avoid sedative, because that may potentiate the effect of sedative drugs. And treatment should be continued perioperatively. That is tricyclic antidepressant. Now, what about the SSRIs that inhibit the presynaptic serotonin reuptake, and that causes the headache, agitation, and insomnia, and also the platelet dysfunction? There is one terminology called that is serotonin syndrome, that that is hypothermia, hypertension, neuromotor disorders, and cognitive behavioral disorders. So this serotonin syndrome appears specifically when these SSRIs are being given along with the tricyclic antidepressant, the MAO inhibitor. They have also interaction with the pentazocine, the pethidine, tramadol, and dextromethorphan. So they also increase the chances of bleeding because they affect the platelet function. They also inhibit the liver enzymes and potentiate the effect of sedatives. The MAO inhibitors that inhibit the breakdown of serotonin, dopamine, norepinephrine, that's why they just potentiates the sympathomimetics, specifically showing that there is very high chances of hypertension by using pantone MAO inhibitors. And abrupt withdrawal may cause suicidal tendency, depression, and so all the irreversible inhibitors should be replaced with the short-acting reversible inhibitor, because they show a dual effect: the excitatory effect due to the serotonergic transmission, and depressive effect due to inhibition of the hepatic enzyme, so potentiates the effect or prolongs the effect of the 5-penton-like drug. Lithium, it is used for the bipolar disorder and intoxication, may cause GI, CNS, and ECG changes, and renal function to be done every 5 monthly. And serum level of these lithium is increased when NSAIDs, ACE inhibitors, thiazide, diuretics, and metronidazole are being given to these patients. It prolongs the effect of both depolarizing and non-depolarizing muscle neuromuscular blocker. It should be stopped at least 3 days before the surgery and restarted when the patient is stable and educated orally. So fasting guidelines are not specifically applicable on the delayed gastric emptying patient, esophageal motility disorder, any pregnant lady, and post-bariatric surgery. So these are the certain drugs which reduce the rate of post-operative nausea and vomitings. So now let's move on to the examination part, the pre-anesthetic evaluation. So in examination, we go for the vital sign assessment, the height and weight, the airway assessment, the neck assessment, heart examination, cardiovascular system examination, the pulmonary system examination, such as vasculature for the arterial access and for the peripheral pulse, abdominal examination to assess the status of the liver, liver and all and extremities. So let's move on to the airway first. So what are the components of this airway assessment? We assess for the any previous, first of all, we take history for any previous issue related with the anesthesia, any presence of the gastroesophageal reflux, about the body mass index, the mouth opening, the Malam-Patti score, teeth examination, upper lip bite test, thyromental distance, so on. So what are the key components of the airway management? First, we want to know whether bag mask ventilation can be done easily or not, whether the supraglottic airway device can be inserted properly or not, tracheal intubation can be done or not, infraglottic airway insertion can be done or not. When it is called that bag and mask ventilation is difficult, when unassisted anesthesiologist giving ventilating positive and giving positive pressure ventilation to a patient with a bag and mask with 100% of I2 is still not able to maintain SQ2 above 90%, where the SQ2 was above 90% before this intervention. Then it is called a difficult bag mask ventilation. So this Khatrapal and colleague suggested certain risk factors for difficult mask ventilation, difficult mask ventilation and intubation and impossible mask ventilation, where the BMI is a common factor above 30 kilogram per meter square, the Malam-Patti score more than 3 and 4, all the situations are difficult, and limited jaw perfusion. Snoring makes the mask ventilation difficult, whereas the sleep apnea makes the mask ventilation intubation both difficult, and sometimes it may make the mask ventilation impossible. So this morphine was difficult bag mask ventilation. There is a mnemonic which has been suggested, where we are by going through this mnemonic, we can assess that whether bag mask ventilation is going to be difficult or not. Where that is MOS and stands for the mask seal. When there is certain situation of the face like poor denture, loose denture, or maxillofacial injuries or beard, or retrogranthia, where the mask doesn't fit properly. So it may lead to the difficult mask ventilation. When the obesity or the BMI is more than 30 kilogram per meter square, then it causes creates a difficulty for the bag mask ventilation. Old age, when the old age where the all the teeth are there are no teeth and identulous situation, the mask may not properly fit. And if the patient snores, a slight sedation may cause the falling of the tongue back and cause the back mask ventilation difficult, and certain causes that cause stiffness of the neck, like stiffness of the neck, like radiotherapy, or stiffness of the airway, like in case of a bronchospasm. Now, the laryngeal mask airway, yes, the laryngeal mask airway insertion may itself be difficult, and sometimes after insertion of laryngeal mask airway, even then the ventilation is difficult. And for this, there is a mnemonic method. It's called RODS. R stands for reduced mouth opening, where that limits the insertion of the laryngeal mask airway. Where O stands for obstruction. Obstruction of the airway may be supraglottic or infraglottic, maybe because of higher bronchospasm, or there is certain mass which is lying over the which is lying present over the glottis, and it creates a difficulty for the ventilation even after proper LME insertion. Distorted airway, definitely the airway distorted, or any tear or rupture and due to any trauma, that may further cause a difficulty in ventilation with laryngeal mask airway. Stiff neck or stiff lungs, as in case of restrictive lung disease, hyperreactive airways, COPD, acute exacerbation of COPD, asthma, or maybe after the radiation therapy, which may cause the neck very much stiff. So that may cause a poor seal of this laryngeal mass airway over the glottis and also inhibits the proper ventilation. Now, difficult intubation, intubation is called difficult when more than 3 attempts or longer than 10 minutes have been taken to intubate the patient. And to assess the intubation difficult, before trying it, we should look for lemon. L stands for external look, any dude and protruding teeth, any retrogranthia, and evaluation of the mouth opening, the thyromental distance, Mallampati score, and obstruction or about the neck mobility. This is called lemon. The Mallampati score, we all know the class 1, class 2, class 3, class 4, class 3, and class 4 are the difficult situations. The modified Cormack-Lehman classification, the prerequisites muscle should be relaxed and adequate size of plate and adequate position should be there. And in the grade 1, the full view of glottis, where the grade 2 and grade 2A and 2B, the partial view of glottis on or only the posterior part of the glottis to be recognized are visible, and grade 3A and 3B, the epiglottis can be lifted from the posterior pharyngeal wall, where in 3B, the epiglottis cannot be lifted from the posterior pharyngeal wall, and the grade 4, neither glottis or epiglottis is visible. So there is one intubation difficulty scale where we score according to different components which are being given, and with the sum of and we do the sum of all scores. So number of attempts is more than 1, and every additional attempt adds 1 point. Number of operators, every additional operator adds 1 point. Any change in or any alternative techniques will add 1 point, like changing the blade, changing the stellate, changing the approach, changing the position, changing the equipment. And Cormack-Lehman grading, apply Cormack and Lehman grade for first oral attempt. Lifting needs any force or easily lifted, any laryngeal pressure is applied or not applied, and the position of the vocal cord is adapted and adapted. So total intubation difficulty score is sum of all scores. So this interpretation of this difficulty intubation score, if the IDS is less than 0, it is easy IDS, and intubation difficulty score is less than slight difficulty, but when the IDS is more than 5, moderate to major difficulty, later on it is impossible beyond. So there is also a front of neck access, that is phona, and the predictors for the difficulty for cricothyroidotomy is represented here by the mnemonic short. If there is any surgery in front of neck, if there is any hematoma or infection, and the patient is obese, any radiation to the neck, or any tumor is present, in that way the cricothyroidotomy is also difficult. There are certain pathological conditions that influence the airway management, that is infectious epiglottitis and abscess, submandibular retropharyngeal locus, angina, papillomatosis, cervical spine injury, the basilar skull fracture, the laryngeal fracture, laryngeal edema, neoplastic upper airway tumors, radiation therapy, inflammatory rheumatoid arthritis, and ankylosing spondylitis, where neck mobility is affected, that proper position cannot be made. And that way, there are certain connective tissue disorder like scleroderma, sarcoidosis, angioedema, diabetes mellitus may have a reduced mobility of atlantic joint, hypothyroidism, large tongue, abnormal soft tissue movement, difficult, obesity, upper airway obstruction with loss of consciousness is there. Now, let us take one by one system-based pre-anesthetic assessment. In pulmonary disease, the major pulmonary complications are respiratory failure in post-operative phase, major ventilation or intubation for more than 48 hours, or pneumonia, and certain minor complications which are like URTI, bronchospasm, epilepsis. So, to assess the pulmonary system, we should elicit the history of shortness of breath, any chest tightness, any coughing, and recent exacerbation of anesthesia-related recent exacerbation of any symptom or anesthesia-related exacerbation in past. Whether the patient is taking any steroid in past years, and use of oxygenation, hospitalization, or intubation of the patient in past 1 year. There must be an examination like use of accessory muscles or the severity of the bronchospasm or the airway obstruction cannot be judged or analyzed by the V's. It is a crude method because if there is a complete obstruction of the airway or complete spasm, there is no V's. So it is difficult. But yes, by having a look of the accessory muscles, use of accessory muscles, you can have an idea about the severity of the airway obstruction. Oxygen saturation is one method to assess the status of the pulmonary function, how much it is affected. Why we are very much worried about the pulmonary assessment? Because the anesthesia itself affects the respiratory system. It decreases the lung volume and the vital capacity. It increases the closing volume, decreases the lung compliance. The bronchodilation may be there due to the inhalation of anesthetic agent, and it also decreases the mucociliary clearance, reduce ventilatory response to hypoxia, hypercapnia, and acidosis. The pulmonary circulation may be affected because of hypoxia. Inhalation and anesthetic reduce the hypoxic pulmonary vasoconstriction, and immune function is also affected by the anesthesia. That's why we need to know the pulmonary status before going for anesthesia. What are the different risk factors for the post-operative pulmonary complication? There are surgery and anesthesia-related risk factors and the patient-related risk factors. The surgery and anesthesia-related risk factors are the duration of anesthesia more than 3 hours, and head and neck surgery, use of endotracheal tube, and intracavitary surgeries like upper abdominal surgeries, thoracic surgery, the cardiopulmonary bypass. But now the laparoscopy has minimizes complications because of the surgery. Now, there are certain patient-related risk factors like the age over 70 years, smoking more than 40 packs per year, pre-existing pulmonary disease, BMI more than 30, FeV1 less than 1 liter, albumin less than 3 grams per deciliter, and ASAPS score that is more than 2, exercise capacity less than 2. What is exercise capacity? That is called a MET scoring. So risk factor. So there are certain risk factors for the acute respiratory failure, specifically when the upper abdominal aortic aneurysm is occurred. The thoracic surgeries, upper abdominal and peripheral vascular surgery, chances of respiratory failure are very high. Albumin is less than 3, plasma urea more than 30. So there are certain scores given in front of them. So we just say whether this component is found in this patient or not, and check for the scores and add on the scores. If the score is less than 10, the risk of the postoperative pulmonary the respiratory failure is less than 0.5%, but if it's 11 to 19 to 1 point. Similarly, we can also check for the postoperative possibility of pneumonia. In COPD, when specifically in COPD situation, when we handle the patients, the patient will end up into the bronchospasm. There are very much high chances of getting infected because the airway is already inflamed and immunosuppressed. In restrictive lung disease, increased inflammatory process, and that leads to the ARDS, and sometimes delayed extubation is also possible. How does this, what should we do with the smoking? We should definitely advise a patient to stop the smoking. How does it help? Because if you stop smoking at least for 1 hour, it reduces the heart rate, blood pressure, and gradually the circulation starts improving. When this smoking will stop at least for 12 hours, the level of the carbon monoxide goes down and relatively oxygenation improves. After 1 day after stopping smoking, risk of heart attack also reduces. 2 days stopping of smoking improves the sense of smell and taste. After 3 days, nicotine level drops and there may be a withdrawal symptom. Though low nicotine level is good for health, but we need to take care of the withdrawal symptoms also. After 1 month of stopping of the cessation of smoking, the lung function and capacity improves, and there is also improvement in the exercise tolerance. And 1 to 9 months, circulation becomes more and more better. After 9 months, there is improvement in the ciliary function and less chances of the infection because overall healing of the airway and the lung having time. 1 year, after 1 year, risk of the coronary artery disease becomes half. After 5 years, blood vessels widens and decreased tendency to clot. There are less chances of the thromboembolism. After 10 years, decreased chances of double lung cancer by half. After 15 years, chances of CAD is equal to non-smoker, and after 20 years of cessation of smoking, the patient is as normal as non-smoker patient. Now we see another clinical condition, that is obstructive sleep apnea, where there is a direct history, and we always go for the direct history and the physical examination and preoperative screening of the OSES, that is obstructive sleep apnea syndrome. So for the preoperative screening, there is a stop blank questionnaire. If the patient is of low risk for the patient is low risk for the OSES, proceed for the surgery with the usual perioperative care. But if the high risk for the OSES, identify the patient
हाँ, इन चीजों के बारे में हमें मालूम पड़ेगा। हमारे
मैंने कभी
गर्दन काट दी तुम। हाँ हाँ
what is it potentials are critical to external conduction? Critical to external conduction. ये वीडियो कहाँ दिखा रहे हैं?
ये वाला तो फिर ऐसे
Synaptic integration something like that will be.
ही अरे
डॉक्टर सुनील झंझारिया। बकवास।
अब क्या होगा, 9:30 बजे तो प्यार गया।
Blood pressure are suggested specifically in the OSA patient, and pre-operative inspiratory muscle training improves, specifically in the COPD, OSA, in upper abdominal thoracic patient. The pre-operative inspiratory muscle training improves the overall morbidity. Correction of malnutrition is also required. Smoking cessation at least for 4 weeks back to the surgery. Renal disease, there are certain risk factors like old age, obesity, use of toxic plant. So there are certain investigations suggested before surgery which can give an idea about the renal status. And in case of anemia, that is hematocrit values should be there, proper cross matching, and blood typing should be done. Now, in case of cardiac disease, yes, and cardiac evaluation, our goal is to identify the high risk heart disease with certain modifiable conditions. Hypertension leads to heart failure, ischemic heart disease, and renal insufficiency all. And each 20 millimeter increase in systolic blood pressure and 10 millimeter increase in diastolic blood pressure above 115 and 75 doubles the risk of the cardiovascular disease above the age of 40. So what is the normal blood pressure? It is less than 130 by 85, where the high normal is 130 to 140, systolic blood pressure 85 to 90. And similarly, the hypertension is stage 1, stage 2, stage 3, and stage 4. So the stage 4, when the blood pressure is more than 210 and 120. So surgery can be postponed if the blood pressure is more than 200 and 150 till the blood pressure comes down to 180 by 110. And 180 and 110 blood pressure, then there is no need of postponement of surgery. If it is elective surgery, then definitely it can be postponed and provide certain treatment unless until the blood pressure becomes normalized. And 6 to 8 weeks is required to overall 6 to 8 weeks. Overall 6 to 8 weeks therapy is required to allow the regression of the vascular and endothelial damage. Never try too rapid lowering of the blood pressure because hypertension is more dangerous than hypertension. So what history we need to illustrate? That is episodic tachycardia, the palpitation, and drug history in young adults like steroid, cocaine, and etc. Because that episodic hypertension. Any risk factors for the ischemic heart disease like age, gender, or any positive family history, examination, the blood pressure in both arms, and hypertension is considered, and high blood pressure reading is noted for 3. And this revised cardiac index has the 6 components. First component, the high risk surgery, specifically the intraparietal and intrathoracic or above inguinal vascular surgeries. If the patient is non-case of ischemic heart disease, patient is having congestive heart failure and cerebrovascular accident or diabetes mellitus requiring insulin and a creatinine more than 2. So the every component has given 1 point. We add on the points and we just create a cardiac risk index. So if
मेरे में जाती कहाँ
area of it. Similarly, we can also adjust the functional status of the cardiac, that is done by the NYHA functional classification. In class 1, no limitation of the physical activity, where the slight limitation of the physical activity but comfortable at rest. And class 3, there is marked limitation of the physical activity, but there is no dyspnea on rest. And class 4, unable to carry any physical activity, and patient is also dyspneic at rest. can be done, but ECG should not be done in any asymptomatic patient. So all the patients who need to undergo the vascular surgery, vascular procedure with any of the one clinical risk factor as per the revised cardiac index should have on ECG. The CHF, cerebrovascular disease, cerebrovascular disease should have the ECG done. With the renal insufficient diabetes should also have the ECG done, and it can also be done with the patient having a long-standing hypertension, the poorly controlled blood pressure, or multiple drug regimes for the blood pressure. They can also have the ECG done. So abnormal ECG needs thorough cardiac evaluation with the stress testing if the ECG is showing left ventricular hypertrophy, pathological Q wave, STT wave changes, and abnormal rhythm like atrial fibrillation, pacemaker, and ventricular arrhythmia. Stress testing has more negative predictive value than the positive predictive value. So if stress testing, stress testing is normal, that means there is least chances of any perioperative major cardiac events. So, and these stress testing are also done specifically in those cases where the ECG interpretation becomes difficult, specifically in case of a left ventricular hypertrophy with left bundle branch block and STP elevation. So in that case, the ECG is less informative. In that case, we can go for a stress test. Now, the echo. Yes, the echo cannot be advised to each and every patient, but it is basically to assess the left ventricular functional status of the patient. If the left ventricular ejection fraction is more than 55%, the mortality rate is 2.2%, and if it is less than 35%, the mortality rate goes up to 20%. And it is to be done if there is any positive history of the left ventricular failure, any previous myocardial infarction, any abnormal finding in the previous echo, or there is sudden change in the clinical condition on newly originating murmur, specifically the grade 3 murmur. The grade 3 murmur that is moderately loud without failure. So in that case, echo can be advised. There are certain preoperative consultation which are also required, specifically in case of a pulmonary, the pulmonary abnormality as well as the cardiac abnormality, and when we send any preoperative consultation to
Okay, my dear friends, I am very sorry that sometimes it always happens when technical faults here is that we are not able to stream our Zoom link to YouTube properly. It works during first lecture very well because that was not a recorded lecture. That was a live lecture, so live lecture run well, Dr. Tuwati sir. After that, the PAC lecture that we are taking pre-anesthetic checkup and perioperative optimization was a video recorded, and it runs poorly even on the Zoom and the YouTube. So now we are planning to do this on Zoom. So we have given Zoom link to almost all the possible participants who are there to join it. So you can show us at least your thumb that the transmission is okay in chat box, because it is very important for us to know that how we are transmitting now. In chat box you can write down regarding transmission quality, is it okay or not? If it is okay, just write okay.
Chat is also disabled, sir, in chat box.
Okay. Disable correct. Okay. So you can even speak. Is the voice is clear? You are able to see my video, my picture.
Chat is disabled.
अभी chat enable कर दिए. So during this lecture, I think this is the one of the common lecture that पूरे 3 साल भी we do the PSE. And even in exam, this has been asked how you will optimize the patient and what drugs to be continued and what drugs to be stopped. Is Dr. Arma Bharti is there as a chairperson? Yes. Okay. So main motto that anesthetic checkup, we want to assess the risk to undergo a surgery under anesthesia, and we have different parameters. What is the status, patient status? Different. We have different risk scoring system based on the patient physical status, based on investigation to assess the cardiorespiratory. Cardiorespiratory is the main one because they increase the mortality during the perioperative period. And how we optimize this come in our pre-anesthetic check. So I am very sorry that it doesn't go well, but I think we are doing it routinely. The airway assessment, the neck examination, the regional, how to give regional anesthesia based on that examination in the patient. So now we are going to the next topic, that is anesthetic management of a pregnant female. And for this session, we have the chairperson. So we have Dr. Indulata, who is a professor, Department of Maternal Reproductive Health in SGPGI, and we have Professor B.V. Kushwaha, who is a professor in Department of Anesthesiology at KGMC Lucknow, and we have myself here for this session. So there are 4 speakers. We have Dr. Ganpat Prasad, who is an assistant professor dealing with the physiological changes. So I request Dr. Ganpat to please, we are making you for you share your slides.
Okay, sir.
Thank you. Dr. Ganpat, we are making your slides. Please open the PPT.
So my screen is visible.
Yeah. आप इसको जरा एक्सटेंड कर दो पीपीटी में पावरपॉइंट प्रेजेंटेशन में कर दो. Good, very good. So it's over to you, Dr. Ganpat, please.
So it is visible, sir. Hello. Hello.
Yeah, Dr. Ganpat, you are audible and visible. Please start your lecture.
Okay, thank you, sir. So myself, Dr. Ganpat Prasad, Assistant Professor, Department of Anesthesia, SGPGI Lucknow. I will discuss here only the physiological changes in the pregnancy. So pregnancy brings about many physiological changes. So these can be divided into 3 areas. First, anatomical, physiological, and biomechanical. We will here discuss only the physiological changes in the pregnancy. So why there is a physiological in pregnancy? This is maybe due to the enlarged uterus and increased demand of the fetus as well as the mother. So pregnancy produces profound physiological changes that alter the usual response to the anesthesia. So we have faced some challenges because we have to care the 2 patients simultaneously. So when we fail to take care of one of them, there may be disaster to both of them. First, we will discuss here the cardiovascular changes. So there in the cardiovascular, total blood volume increased by 35%, plasma volume increased by 45%, and the cardiac output increased by 30 to 50%. These increase is due to increased meet of the demand for the fetus and as well as the mother. And there is the slightly increase in the heart rate, that is 20 to 30%. But there is the reduction in the systemic vascular resistance that is decreased by the 15 to 20%. But CVP remain unchanged in the pregnancy, and the systolic and diastolic blood pressure also decreased. And the systolic blood pressure decreased by 5%, and the diastolic blood pressure decreased by 15%. So more reduction in the diastolic blood pressure. So as the increase in the plasma volume and the excess of the red cell mass, there is the dilutional anemia and the reduced blood viscosity. This is also known as the physiological anemia of the pregnancy. A decrease in the systemic vascular resistance by second trimester decrease both diastolic as well as systolic blood pressure, as discussed in the previous slide. There is also the response to adrenergic agent and vasoconstrictor also blunted. At term, maternal blood volume has increased by 1000 to 1500 ml in the most of the women, which allow them to easily tolerate the blood loss associated with the delivery. So total blood volume reaches 90 ml per kg of the baby body. Average blood loss during the normal vaginal delivery is 400 to 500, and during the uncomplicated cesarean section, 800 to 1000 ml. So blood volume does not return to normal until 1 to 2 weeks after the delivery. Cardiac chamber also enlarged, and myocardial hypertrophy also noted on the echocardiography. Pulmonary artery, CBP, pulmonary artery bed pressure remain unchanged or minor change in the pregnancy. But there is the greatest increase in cardiac output as seen during the labor and immediately after the delivery. And cardiac output does not return to normal until the 2 weeks of the. But CBP increases 4 to 6 centimeter of water due to contraction of the uterus. And due to elevation of the diaphragm, heart moved to left and upward. So apex shifted to lateral. There is some ECG changes in pregnancy. There is increase in the heart rate that is 15%, that sinus tachycardia, and left axis deviation may be seen. And there is the small Q wave and inverted P wave also noted in lead 3 in pregnancy in ECG. There is the increased RS ratio in B5 and B2 in ECG in pregnancy. Heart sound. Apex beat shifted to left intercostal space and 2.5 centimeter lateral to mid-clavicular line. And systolic murmur may be seen over the heard over the apical and pulmonary area. This is due to the decrease in the blood viscosity and torsion of the great vessels. And the memory murmur also heard during the period of pregnancy. It is the continuous hissing murmur seen over the third and fourth intercostal space due to the increased blood flow through the internal memory vessels. Third heart sound also noted this is due to the rapid diastolic filling. And some echocardiographical changes also seen in the pregnancy there, and this is due there may be the slight increase in the end diastolic and systolic blood volume, slight improve in the left ventricular function, slight increase in the ventricular dimension with spherical left ventricular remodeling, a small benign pericardial effusion may be seen, increased tricuspid annular diameter, physiological tricuspid regurgitation may be seen, but there is no change in the septal thickness or ejection fraction. So as the uterus enlarges, so this compress the IVC and lower aorta when the patient lies in the supine position. Due to this, there the obstruction of the IVC, and which lead to decrease in the venous return, which lead to decrease in the cardiac output. So when the patient awake, most of the patients are capable of compensating for the decrease in stroke volume by increasing systemic vascular resistance and heart rate. There are also the alternative venous pathway, that is the paravertebral and the azygous system. But during the anesthesia, the compensatory mechanisms are reduced or abolished. So obstruction of the lower aorta causes reduction of the blood flow to kidney, uteroplacental unit, and the lower extremity. Supine hypotension syndrome. This is seen in 8 to 15% of pregnant women due to compression of the IVC or lower aorta. This is associated with the hypotension, sweating, bradycardia, pallor, nausea, and vomiting. So this can be prevented by displacing the uterus by placing the rigid badge under the right hip and by tilting the table left side down 15 to 20 degrees. But during the regional anesthesia, like spinal or epidural anesthesia, there may be profound hypotension. So this can be prevented by lateral tilt of the table. Now respiratory changes in the pregnancy. So as you see that the oxygen consumption is increased by 20 to 50%, airway resistance decreased by 35%, minute volume ventilation increased by 50%, and tidal volume increased by 40%. Respiratory rate, there is the slight increase in the respiratory rate, that is the 15%, and the partial pressure of the oxygen increased by 10%, but there is the reduction in the partial pressure of CO2 by 15%, and concentration of bicarbonate also decreased by 15% to compensate the bicarbonate CO2 level, and FRC also decreased by 20% in pregnancy. So the maternal respiratory changes due to the enlarged uterus. In the third trimester, elevation of the diaphragm is compensated by increase in the epidiameter of the chest. So there is the more thoracic breathing rather than the abdominal breathing. Both vital capacity and closing capacity are minimally affected in pregnancy. FRC decrease up to 20% at term, and FRC return to normal within 48 hours of the delivery. There is the reduction in the expiratory reserve volume also noted. In this slide, you can see that functional residual capacity, residual volume, expiratory reserve volume approximately decreased by 20% in the pregnancy. Vital capacity, inspiratory reserve volume, closing volume, these remain unchanged in the pregnancy. Total lung capacity approximately decreased by 5%. Inspiratory capacity increased by 5%. So anesthetic implications, as the FRC decrease and the increased oxygen consumption. This promotes the rapid oxygen desaturation during period of apnea. This is more common, marked in the obese pregnant female. As the FRC decrease, which causes airway resistance, airway closure 50% in the 50% of the patients at term in supine position, making pre-oxygenation less effective in the pregnancy. So while giving regional block, this further diminishes the FRC, which lead to rapid development of the hypoxemia in the pregnancy. So pre-oxygenation prior to induction of general anesthesia is therefore mandatory to avoid the hypoxemia in pregnant female. There is the capillary engorgement and edema of the upper airway due to down to the pharynx, false vocal cord, glottis, and arytenoid. So increase in chest diameter and enlarged breast can make laryngoscopy more difficult in the pregnant female. So failure to take intubate the trachea is 7 times more common in the term pregnant female as it is non-pregnant female. A smaller diameter endotracheal tube may be required for the intubation, especially in the case of preeclampsia, and blood flow to the nasal mucosa is also increased. So oropharyngeal intubation is more preferred over the nasopharyngeal. Now coagulation changes or hematological changes. Fibrinogen level increase twice, and there is the slight increase in the factor 2 and factor 5, but marked increase in the factor 7 in the pregnancy. There is the increase in the 10 times. Factor 8 also increase 2 times. Factors 9 and 10 also increase, but there is marked reduction in the factor 11, that is the 70%. And factor 12 also increased by 40%, and the factor 13 is decreased by 40%. Bleeding time, PT and APTT remain unchanged in the pregnancy. As you know, pregnancy is the hypercoagulable state, so there is the increased risk for thromboembolic episode. GIT changes. The participants should be considered a full stomach patient during the most of the gestational week, because upward and lateral displacement of the stomach by the uterus promote incompetence of the gastroesophageal inspector and decrease in the gastroesophageal angle, and the reduction of the lower esophageal inspector pressure due to increased progesterone level. Due to these, there is the increased risk of regurgitation and aspiration of gastric content, and there is the increase in the placental gastric secretion, which further worsen the gastric acidity. CNS changes. As you know, minimum alveolar concentration is decreased by 40% due to increase in the level of progesterone and beta endorphin in the pregnancy. Due to combined effect of the increased minute ventilation, decreased FRC, and decreased MAC, there is the rapid induction with inhalational agent in the pregnancy. The amount of local anesthetic drug also less required as compared to the non-pregnant female. Exaggerated lumbar lordosis may be there in the pregnancy, which contribute to cephalad spread of the local anesthetic. Engorged epidural plexus of the vein will decrease the volume of the epidural and subarachnoid spaces. The CSF pressure also increase due to compression from epidural vein in the epidural spaces. Increased sensitivity to opioids, sedative, and local anesthetic when used for neuralgic anesthesia. It is due to the increased level of the progesterone. Renal changes. Renal vasodilation, increased renal blood flow early during the pregnancy. Increased cardiac output lead to increased GFR and increased renal plasma flow by 50%, which increased clearance of the urea, uric acid, and creatinine level. Increased renin and aldosterone level promote sodium and leading to volume overload. Decreased renal tubular threshold for glucose and amino acid may cause the mild glycosuria or proteinuria in the pregnancy. Progesterone mediated uteric smooth muscle relaxation can lead to unistasis, making pregnant women prone to UTI. Hepatic changes. Hepatic function and blood flow remain unchanged in the pregnancy, but there is the mild decrease in the serum albumin due to expanded plasma volume. Thus, a free function of albumin-bound medication is increased. A 25 to 30% decrease in the serum pseudocholinesterase activity also present in the term, but it rarely produces significant prolongation of succinyl choline action. There is the increased cholesterol gallstone formation due to increase in the level of the progesterone. Thank you.
Thank you, Dr. Ganpat. It is very extensive. You have enlisted and shown that physiological changes. So, any comment from the chairperson?
Yes. Actually, Dr. Ganpat, it was a nice presentation, and the physiological changes of pregnancy is usually in a vast degree. If any system is affected due to any compromise, then it affects, you can say it affects more severely due to pregnancy changes in any system of the body. Like in CVS, there are many physiological changes, and if some pregnant woman is affected by some cardiological problem, then it affects with more severity and in more fatal form. So we have to we have to keep in our mind that what are the physiological changes during pregnancy before tackling any problem in pregnant patients. So just I want to say that.
Okay, ma'am. Thank you.
I will only say for the students, when in exam it is come to you that enumerate, so you just enumerate the physiological changes. It can be part of a long question, but in practical, when examiner asks you and what are the physiological changes during pregnancy, either they can ask you like a blunt question and you have to start, or they can ask what is the cardiac changes, what is the respiratory changes, or what is the changes in the blood. So I only say in an exam, when it is asked the physiological changes due to pregnancy or pediatric age group or elder age group or obese patient, it should not be means if examiner asking you every time and then you are giving answer, it shows that you are dealing with a patient 3 years during training, but when you come to exam, you have to remember they have to poke you every time and then you are giving the answer. So it gets very irritating that what the question answer that should come in 5 minutes, it takes half hour or 1 hour to end your one long case. And when examiner in exam want to know that you have a minimum knowledge and skill to safely conduct a case. This is the only thing we want to assess from a student that is passing MD or DNB or DA that has undergone training. You have done work for 3 years, but when you are coming to exam, I can understand that in exam there is apprehension, there is an anxiety, but it doesn't mean that I will not speak or I will speak only less than what I know. That means if I will not speak clearly or loud or with confidence and the content of the answer is not related, it should have a minimum passing marks, then we have problem. That depicts, it's not about the language, the English or Hindi. If you are more efficient in Hindi, say in Hindi. If you are more efficient in Tamil, say in Tamil, because your local examiner understands this. But if the examiner is coming out from the other state and he doesn't understand the local language, then you can ask him or so that you can explain well. I only want to say when examiner say enumerate the physiological changes, it should finish in 5 minutes. That shows you are very efficient. Otherwise, it shows what you are doing 3 years. If you don't know the knowledge, the theory part, how you will imply this in a skill part. So that make a difference. You are just passing or you are a topper student means you are going gold medal. So that is a difference. It should come out 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 does. Thank you. So now we are moving from physiological changes to further long case that you will, or a practical case, a patient, pregnant lady with a hypertensive disorder. So we have Professor Usha Shukla Madam. She is a professor head from UP University of Medical Sciences from Safai. So Dr. Usha Shukla Madam.
Yes. Hello.
Yeah, please.
Hello. Hello. Good evening. Good evening. Hello. Am I audible?
We have made you the co-host. Please share your slides.
Hello. Hello, Dr. Sandeep. Am I audible?
मैडम आप ऑडिबल हैं, आपका वीडियो
No, video may not be there because I am logged into from desktop. No.
Okay,
Hello.
तो आप स्लाइड्स खोलिए मैडम, शेयर में जाइए, शेयर स्क्रीन करिए.
Okay.
Yes. ठीक है मैडम, आपकी स्लाइड्स देख रहे हैं आप इनको. गुड, वेरी गुड. We are able to listen you and we are able to see your slides. Please, ma'am,
Okay.
start.
Okay. Thank you. Thank you, Dr. Sandeep. Good evening, everyone. Good evening, chairpersons and my dear students. Today we shall be discussing the pregnancy with hypertensive disorders. So, as you all must be knowing that the hypertension is a most common medical disorder of pregnancy, and it affects approximately 6 to 10% of pregnancies. And it's a leading cause of maternal mortality and an important risk factor for fetal complications, as you all must be knowing. So all the students must be very thorough about these pregnancy with hypertensive disorders, as they encounter these patients on a daily basis, I must say. So in exams also many questions are asked. You may get patients in pre-anesthetic clinic. You may get an emergency call of these patients. You may get a call for ICU admission and so on. So let's start with the topic. Coming on to the case scenario first. Now in the OPD, we get a patient of 24-year-old age, female patients with average build and nutrition, and comes to the OPD with the complaints of cessation of menses for 8 months and all the signs of symptoms of pregnancy and swelling all over the feet for few days. Patient gives a history of headache and swelling all over the body for past 1 week, which is progressive and was associated with excessive weight gain. On examination, on history, patient did not came for any ANC clinic for ANC visits in the first and second trimester and also in the third trimester. Although when the patient came, she had no history of cough, dyspnea, palpitation, chest pain, and any drug allergy. And also she doesn't have any history of chronic symptoms or signs of preeclampsia or any hypertensive disorder. Now, in the past history, there was no suggestive history of any chronic disease. And on examination, the patient had a very poor general condition. The pallor was there and pedal edema was there, though there was no icterus cyanosis or no lymphadenopathy. On systemic examination, the per abdominal examination was uterus was 28 to 32 weeks, fetal heart rate, fetal heart sound was present, and movements as told by the patient that there are. Respiratory system examination was within normal limit, as well as the cardiovascular system examination. The central nervous system examination, patient was conscious, oriented, and obeyed commands. The GCS was 15 of 15. And while recording the vitals, we had a pulse rate of 90 per minute with a blood pressure of 160 by 90 millimeter of mercury. And the patient had a respiratory rate of 18 per minute, which was regular. On the biochemical investigations, we had hemoglobin. We will be discussing only the relevant investigations and relevant clinical features. The hemoglobin was 8 gram% and the TLC was 10,900. Platelets were 92. And patient had a serum creatinine of 1 mg%, uric acid of 5.7 mg per deciliter. On liver function tests, the bilirubin was 0.7. Total proteins were 3.8 gram% and Ag ratio was 0.8. On urine examination, the albumin was 3+ and the total urinary protein was 0.3 gram per day. So what is the differential diagnosis? So as you know that the hypertensive disorders, they encompass a range of conditions, like patient may have chronic hypertension, patient may have gestational hypertension, patient may have preeclampsia, or eclampsia can superimpose on chronic hypertension. Patient can have eclampsia if she has any CNS symptoms. So it is difficult to diagnose because the clinical presentation is often very similar, despite there are complex differences in the underlying pathologies and the prognosis. So now we have to differentially diagnose this patient. So these are the differential diagnoses. As I have discussed, there can be gestational hypertension, preeclampsia, chronic hypertension, and chronic hypertension with superimposed preeclampsia, eclampsia, HELLP syndrome, etc. So what are the positive findings in our patient? Our patient has headache. She has swelling over the feet. Patient has a history of weight gain, pedal edema, and pallor. On the lab findings, we had the serum protein of 3.8, the urine albumin is 3+, protein 0.3, and uric acid is 5.7, that is slightly raised. Now, our patient did not have any history of severe symptoms of preeclampsia like dyspnea, chest pain, or pain in abdomen, bleeding from any site, and blurring of visions. Now, as our patient is 32 weeks gestation and the blood pressure is 160/90, proteinuria is there. So the gestational hypertension is ruled out. Why? Because gestational hypertension, it occurs after 20 weeks of gestation, and most of the cases, they appear after 37 weeks and or during first 24 hours postpartum. The blood pressure is little bit high, systolic more than 140, diastolic more than 90, but there is no proteinuria. And the hypertension, it resolves by 12 weeks postpartum. Although these patients have a risk of having in the future pregnancy, they may have preeclampsia or gestational hypertension the next pregnancy. Coming on to the chronic hypertension. So as our patient does not have any previous history of hypertension or no family history of hypertension, and the hypertension was noted for the first time after 20 weeks of gestation. In the chronic hypertension, the hypertension is in the pre-pregnant state. And this hypertension persists even after 12 weeks postpartum. So our patient doesn't seem to have chronic hypertension. Now, coming on to the next differential diagnosis, that is preeclampsia. The blood pressure is high. As you see, edema, headache, proteinuria is there, history of weight gain is there, and the onset of hypertension is at the more than 20 weeks of gestation. So our patient may have a diagnosis of preeclampsia. What happens in preeclampsia? There is new onset of hypertension and proteinuria after 20 weeks of gestation. And the diagnosis of preeclampsia can be made even in the absence of proteinuria also, because proteinuria is a late sign. And if the patient has hypertension or any of the sign and symptom of end organ involvement, if there is any, then we can diagnose a patient is that this patient is having a preeclampsia. For example, if the patient has persistent epigastric or right upper quadrant pain, patient has cerebral symptoms, patient has fetal growth retardation, there is thrombocytopenia, or there are any elevated serum liver enzymes. So next is eclampsia. As our patient does not has any CNS involvement, then the eclampsia is ruled out. However, these patients may land into this emergency at any time. And so one should be cautious enough to take appropriate measures if they are not taken previously. So you can see that eclampsia is defined as the convulsions and or coma which are not caused by coincidental neurological disease which occurs during pregnancy or after delivery of the baby in whose the condition also meet the criteria of preeclampsia. Now, the preeclampsia superimposed on chronic hypertension is ruled out because there was no previous history of hypertension, there was no family history, no proteinuria antedates pregnancy or before 20 weeks, and no history suggestive of chronic hypertension. What happens in superimposed preeclampsia over chronic hypertension? That the proteinuria is of new onset and is more than 300 milligram per 24 hours. But no proteinuria before 20 weeks of gestation, or there is sudden increase in proteinuria or blood pressure or platelet count becomes less than 1 lakh in a woman who has hypertension and proteinuria before 20 weeks of gestation. Now, coming on to the main disorder, that is preeclampsia. What is preeclampsia? as I've already discussed, that it is a multi-system disease and it is characterized by diffuse endothelial dysfunction, in which there are maternal complications like patient may have placental abruption, patient may have pulmonary edema, acute renal failure, liver failure, stroke, etc. And there are neonatal complications also, which can lead to preterm delivery. There may be fetal growth retardation, and there can be a hypoxic injury, and even perinatal death can be there. So it's a very important entity which every anesthesiologist must understand, and every anesthesiologist must be ready to deal with these patients. Now, what is the pathophysiology? What is the pathophysiology of this condition? The pathophysiology is the exact mechanism of this pathophysiology is not known, but what is conceptualized is that it is the abnormal placentation, the delivery of the placenta, because it is the presence of trophoblast which is responsible for this pathophysiology. As we know that when the delivery of placenta is there, the disease resolves itself. So preeclampsia is a two-stage disorder. What happens? The asymptomatic first stage occurs early in the pregnancy, in which there is impaired remodeling of the spiral arteries. In normal pregnancy, what happens? The embryo-derived cytotrophoblast, they invade the decidual and mymetal segments of the spiral arteries. They replace the endothelium and cause the remodeling of vascular smooth muscles and the inner elastic lumina. The luminal diameter of spiral arteries, that it increases fourfold. It increases, and what they create? They create a flaccid tube that provides the low resistant vascular pathway to the intervillous space. So in normal patient, these remodeled arteries, they are quite unresponsive to vasoactive stimuli, and this alteration in the maternal vasculature, what it leads to, it ensures the adequate blood flow which nourishes the growing fetus and placenta. In these preeclamptic patient, what happens? The cytotrophoblast which invades the maternal tissue is incomplete, and what happens? Only the decidual the decidual segments, it undergoes change, and these arteries are not invaded and remodeled sense, and they remain small and constricted. So they complicate these hypertensive disorders. They complicate around 10% of the pregnancies, and preeclampsia 5%. As you can see here, that the capillaries become the capillaries. There is this is the slide showing the normal and the preeclampsia changes in the decidual vessels and normal preeclamptic pregnancies, as you can see here. Now, the capillaries, they become leaky with the movement of protein into the interstitial space. And what happens? The endothelial cells, they produce the decreased amount of PGI2, which is an endothelin-derived vasodilator, and it activates the platelets and procoagulants. What happens in the activated platelets? The activated platelets, they produce more of the thromboxane A2 and 5-HT, which promotes the vasospasm. So the autoimmune theory is also there, which tells that there is an imbalance between the PGI2 and thromboxane A2. Now, as we can see that there is abnormal placentation, there is the vascular tone, the permeability, and the fibrin deposition in the endothelium, it increases, and in the blood, the platelets, the prostacyclin, antithrombin 3 levels are decreased, Hence, there is release of more of the thromboxane A2, more of the vasoconstrictors, procoagulants are there, and all these factors they interrelate and ultimately lead to DIC and hemolysis. We can see that the endothelial damage is there, which leads ultimately to the HELP syndrome, as there is decreased production and sensitivity to vasodilators, which leads in the increase in the systemic vascular resistance, ultimately to hypertension. The sensitivity to vasoconstrictors becomes very less, leading to decrease in GFR and renal blood flow. Then what happens? The renin there is a decrease in the plasma renin levels, the aldosterone escape is lost, and there is more of the sodium and water retention, leading to hypertension and edema. The glomerular capillary permeability is increased, and there is proteinuria, which adds to the edema and preeclampsia states. Hello? 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 Am I audible? Hello?
Yes,
Am I
ma'am.
audible?
Yes,
Yeah.
ma'am.
So
Yes,
in
you
the
are audible.
yes,
Yes,
okay.
audible.
Actually, I was getting a message on the screen that the host want to mute you. I don't know.
आप बहुत अच्छा बोल रही हैं, तो होस्ट चाहता है कि आप आराम से बोलती रहें और बाकी लोग प्लीज ऑफ रखें अपना ऑडियो एंड वीडियो.
Actually, I'm
Thank
not getting any response from your side. So I thought that I may not be audible to you guys. That's why I asked. Okay. Okay. So in the cardiovascular system, the hypertension is the most early sign, and as we have discussed that the responses to catecholamines are exaggerated, and there is increased sensitivity to angiotensin 2. There is no consistency among cardiac output, mean arterial pressure, systemic vascular resistance. The SVR is raised and the cardiac output ultimately may go down. And there is a significant disparity between the pulmonary artery occlusion pressure and central venous pressure. We have discussed that their plasma volume is reduced in concert with the severity, and the colloid osmotic pressure is reduced. Now, because there is this despite there are normal filling pressure, the intravascular volume is reduced to 30 to 40%, and there are variation in presentation which depends on the prior treatment, if the patient is getting any prior treatment or severity of the disease, and what is the duration of disease. The total body water is increased as there is generalized edema, and depending upon the severity, there are variations from high cardiac output state with low systemic vascular resistance to low cardiac output and high SVR. So these patients are prone to develop pulmonary edema, not only because of reduced colloid osmotic pressure, which falls further postpartum. In the airway and respiratory system, as we have already discussed, that there is increase in the sodium and water retention, the colloid osmotic pressure is reduced, the capillaries become leaky because of the endothelial dysfunction, and there is generalized edema, as well as there is edema of the airway and the respiratory system. And there are more chances of patient having the laryngeal edema and distortion of glottis, which can lead to difficult airway. So one has to be very, very cautious while dealing these patients, because there are chances for an anesthesiologist to land into a difficult airway situation. And as you know that in the pregnancy state, the mucosa is friable, and in these cases, it becomes more friable, which can lead to trauma while you are intubating or while you are doing laryngoscopy in these patients. Now, coming on to the renal system, we have understand that the renal blood flow and GFR are decreased. Renal failure is there because there is a decrease in the plasma volume, or there is renal artery vasospasm. There is proteinuria because there is a glomerulopathy, there is edema of the glomerulus, and this swelling, this leads to subendothelial protein deposits. The renal functions, however, the renal function, they recover very quickly, but if there is postpartum oliguria, it means that your preeclampsia is severe. Its severity correlates with the oliguria. In the liver, the epigastric pain is if the patient is complaining of epigastric pain, or if the patient complains of pain in the right hypochondrium, it warrants imaging. You should take the patient for imaging, for MRI, for CT, because it is usually accompanied by increase in the liver enzymes, and it is caused by the liver swelling. There may be chances of periportal hemorrhage, there are chances of subcapsular hematoma, and there can be chances of hepatic rupture, which adds to the mortality of these patients. Now, in the coagulation system, these patients are generally in the hypercoagulable state with the evidence of platelet activation. The platelets are activated and there is increase in the fibrinolysis. The thrombocytopenia is common, but less than 10% of patients have a platelet count of less than 1 lakh. In these patients, DIC may occur, and especially in the cases of platelet abruption, placental abruption, or if the patient has IUD or patient is having PPH. Now, in the neurological system, the patient may have headache, patient may complain of visual changes, scotoma, ultimately patient may land into seizures. There is increase in the reflexes, the hyperreflexia may be there, and there are eclamptic seizures. But these seizures may not relate with the hypertension, because the possible cause may be the hypertensive encephalopathy and cerebral edema, thrombosis and vasospasm of the cerebral arteries. In the eyes, the patient has retinal arterial spasm, retinal edema, there can be retinal detachment and ultimately blindness. Now, what are the maternal complications of this disease? There is systemic hypertension, as we have already discussed. Patient may have congestive heart failure. As there is colloid osmotic pressure is decreased, patient may have pulmonary edema. There is arterial hypoxemia, laryngeal edema, cerebral edema, and cerebral hemorrhage. Patient is hypovolemic. There may be HELP syndrome, DIC. There may be epigastric pain, and because of the decrease in the uterine blood flow, there can be premature labor and delivery, and patient can have placental abruption. In the fetal complications, we have discussed, there is prematurity, there is growth retardation, there can be small for dead babies can be there. The patient may aspirate meconium. So the leading cause of intrauterine morbidity and mortality is uteroplacental insufficiency, which is caused by the placental infarcts and is followed by the placental abruption and chorioamnionitis. Now, what is the management? How will you manage this case? When this case comes to you, how will you manage this case? There is medical management, and there is a management from anesthetic point of view. So what is the goal? First of all, you have to stabilize and deliver. Now, what are the lab investigation you should get in these patients? When the patient comes to you, you must get a hematocrit done, get an hemogram done, go for platelet count, get an coagulation assay, do serum electrolytes, get a renal function test done, get serum creatinine, get serum uric acid, go for LFT, go for urine examination, routine microscopic, and go for blood grouping cross-matching if at all you required any blood in the intrapartum stage. Now, for the medical management, what are their goals? If the fetus is less than 34 weeks, then they will have to wait for quite some time. And if the patient is stable, they'll use steroids for 48 hours for lung maturity. They maintain blood pressure, especially diastolic blood pressure between 105 to 110, and they go for seizure prophylaxis in the form of magnesium sulfate. Always monitor these patients for fluid balance, strict input-output charting, take daily weights, look for symptoms arising for severe preeclampsia, look for reflexes, platelet count should be done, regular platelet count should be done, go for serum liver function test and proteinuria. Now, what is the definitive treatment? Definitive treatment is the delivery of fetus and placenta, because the presence of trophoblast is the main causative factor of this condition. Despite, apart from the general management and supportive treatment, control blood pressure, correct intravascular fluid volume, maintain urine output, prevent seizures, and manage accordingly the associated maternal complications. So what is the medical management of hypertension? First and most important is the medical management of hypertension. What is your goal? You have to maintain the blood pressure, systolic blood pressure between 170 and 130, in the range of 170 to 130, and diastolic blood pressure in the range of 90 to 110. Always avoid precipitous fall in blood pressure. Use IV fluid judiciously and go for prehydration. That is, go for volume expansion. So for acute treatment of hypertension, we use labetalol. It is the most commonly used antihypertensive in this patient and in these patients, and it's having faster onset. The onset is very fast, and it is relatively free of maternal side effects like tachycardia and there is no decrease in the cardiac index. There is no decrease in the uterine blood flow and fetal heart rate. It has the advantage of alpha-adrenergic blocking effect on uteroplacental vasculature. The doses are 10 to 20 milligrams slow intravenously, and they can be repeated according to the response. Always be cautious when you use this drug in asthmatics and CHF. It's always better to avoid this drug in these patients. Coming on to the hydralazine, it is also used because it also has a rapid onset, short duration, and has a direct effect. But the disadvantages are that it causes tachycardia, it causes headache, tremors, and vomiting. The doses are, as you know, that 5 to 10 milligram intravenously every 20 to 30 minute infusion. Now, there are other direct vasodilators like nitroglycerin and sodium nitroprusside. They can also be used, but there is a risk of excessive hypotension, and there is a risk of decrease in the uterine blood flow, and in the high doses of nitroglycerin are used, there is a risk of methemoglobinemia. With sodium nitroprusside, you have the risk of cyanide toxicity, so it's always used for short-term administration. And for both these drugs, you have to get an intra-arterial monitoring, as these are direct vasodilators, and there is a risk of excessive hypertension is always there. So what is the treatment of chronic rise in blood pressure? We have many drugs like methyl-dopa. It's the most commonly used agent. We can use labetalol, hydralazine, and clonidine. The beta blockers are beta blockers. There is a risk of fetal bradycardia. With calcium channel blocker, the magnesium sulfate effects are potentiated. Hence, they should be used cautiously. ACE inhibitors are not recommended as they have teratogenic potential. The angiotensin 2 antagonists, they have a fetal risk, and with atenolol, we have a risk of fetal maldevelopment. The diuretics, as you know, they are not preferred in this patient. So next comes the volume management. Always correct intravenous, always correct the fluid deficit. Correction of IV fluid volume before antihypertensive. When you start antihypertensive, you should always correct the fluid deficits. You can use crystalloid solutions in the doses of 1 to 2 ml per kg per hour, with the adjustments based on the patient's clinical condition and urine output. CVP measurements and pulmonary artery catheter in selected cases the indications are very less, and you have to always look for coagulopathy in this patient before using CVP measurement and pulmonary artery catheter. Colloid solution, they have a limited role, and the controversy is still there, though they are said to improve colloid osmotic pressure, but there is a risk of increased CVP and pedal edema, and also there are evidences that the outcome also does not improve. The rapid infusion of dextrose containing solution should be avoided because they result in excessive maternal blood sugar and neonatal hypoglycemia. However, we can use half DNS in the doses of 7 to 10 ml per hour, and it is very well tolerated in this patient. Avoid dextrose in water alone if oxytocin is added to IV fluid to prevent water intoxication because it has an antidiuretic effect, and transfuse blood when the hematocrit is less than 27%. Accordingly, as per the need, you have to use platelets and FFP. Now, the oliguria. If the patient has oliguria, then you have to challenge the fluid. You have to give a fluid challenge of 500 ml of crystalloids. And if there is no effect, you can use dopamine infusion in the low doses. Always avoid repetitive unmonitored fluid administration because of the risk of pulmonary and cerebral edema. The CVP monitoring can be done if there is persistent oliguria, but always look for coagulopathy if there is any in these patients. Coming on to the seizure prophylaxis, we know that we use magnesium sulfate for this problem, and the seizure, it is used in the eclampsia, it is used for the seizure treatment, and in the preeclampsia, it is used for seizure prophylaxis. The loading dose is 4 gram. 20% solution over 5 minutes, and it is followed by the continuous infusion of 1 to 2 gram per hour. So how does it act? Because it has a both peripheral and central effects. It blocks the calcium via NDMA and reverses the cerebral vasoconstriction. It decreases the presynaptic release of acetylcholine, and the postjunctional sensitivity to the ACH is also decreased. There is mild relaxant effect on the vascular and uterine smooth muscles. The fibrin deposition, it decreases, and it increases the hepatic and renal circulation. So it is also not without adverse effects. The toxicity is also there. Toxicity from overdoses is mainly respiratory and in the cardiac system. There are increased chances of bleeding. There is increased hypotension with hemorrhage, and there is decrease in the uterine contractility. It is urinary excreted drugs. So these patients, and we know that these patients are very prone for renal failure. So we have to be cautious and monitor the magnesium levels frequently. Either clinically, we have to both look for clinical reflexes and check the serum levels. At therapeutic levels are 4 to 7 milliequivalents, and the patellar reflexes are lost at the when the serum levels are 8 to 10 milliequivalents per liter. When the serum levels increases, there is respiratory depression, there is respiratory paralysis, ultimately leading to cardiac arrest. So what is the treatment of magnesium toxicity? Stop magnesium sulfate, give calcium gluconate or calcium chloride in the doses of 300 milligram along with flucimide, and manage the airway. Now, what are the indications that need an urgent delivery? Is the fetal distress? You may get a call of fetal distress, or there is persistent refractory hypertension. There are worsening end organ functions. There is HELP syndrome, or there is development of eclampsia. So, what is your role? The role of anesthesiologist in preeclampsia is very important because you are familiar with the drugs that makes us potentially key figure in the multidisciplinary management of these patients. The provision of anesthesia and analgesia for operative and non-operative delivery in this patient provide you a particular clinical challenge. It requires a skill and experience on the part of an anesthetist. As we know that it is a major cause of maternal mortality and fetal loss worldwide, and particularly in the developed country, developing countries like ours. So what is your role? your role is very important. You have to provide the pain relief. You have to manage respiratory and cardiovascular functions. You have to control the fluid balance, and you have to prevent as well as manage life-threatening complications which may arise from this condition. Now, you have to first pre-evaluate, do a pre-anesthetic assessment. Always look for aspiration prophylaxis. Pay a particular attention to the airway management. As we have discussed that there is facial edema, there is laryngeal edema, so you may land into a difficult airway situation anytime. These patients are at risk of pulmonary edema, so the hydration should be judicious. Now, how will you anesthetize these patients, or how will you give a pain relief to these patients? You have two choices, either regional or general. So what are the concerns regarding the regional block? As you know that there is a chances of severe second fall in the blood pressure. So because the patients are volume contracted, and we have discussed that you should always go for prehydration, but it should be judicious because the risk of pulmonary edema is also there, and the excessive fluid administration may lead your patient to pulmonary edema. There is a risk of using the pressure agents to treat the secondary hypotension which is caused by your regional blocks. So invasive monitoring, as far as invasive monitoring is concerned, you have to be cautious, and it should be only be done when it is actually indicated. So what about the CVP monitoring? For CVP monitoring, you have to, when you should do CVP monitoring, when there is persistent oliguria, or there is difficulty in fluid management, or the patient has pulmonary edema. But always get a coagulation profile done beforehand. What are the indications of intra-arterial blood pressure monitoring? If the hypertension is refractory, if you are planning for vasodilators like NTG and sodium nitroprusside, or the NIBP measurement is difficult. The patient is having obesity and you are not able to measure the blood pressure non-invasively. Now, we have discussed about the laboratory assessment. The hematocrit should be done because it suggests the hypovolemia. Thrombocytopenia, you know that it occurs in most of the patients. The platelet count of less than 70,000 indicates an increased risk of epidural hematoma. The test for platelet functions is useful in evaluating the patient's eligibility for regional anesthesia if the platelet count is in the range of 70,000 to 1 lakh. However, one single figure of any platelet count is not helpful in deciding the regional anesthesia. So you have to look for the trend. What is the trend of platelet counts? Because preeclampsia is a dynamic disorder, and rapid fall in a very short interval, it may warrant the concern. So you have to look for the trend in the platelet counts. Next comes the liver function test. Blood urea nitrogen and serum creatinine. They determine the severity of preeclampsia, or they identify the presence of HELLP syndrome. Get an ABG and chest radiograph if possible, because if there are any signs and symptoms of pulmonary edema. However, in a pregnant patient, we discourage chest radiography. Also, we don't have time for this investigation. Now coming on to the epidural benefits of epidural anesthesia. It provides a pain relief. The beneficial hemodynamic effects are there because there is reduction in the blood pressure with a small reduction in the systemic vascular resistance. And the SD fluid ratio, the SD ratio in the uterine artery is decreased by 25% of levels as seen in the preeclamptics, and there is decrease in the vascular resistance and relief of the vasospasm. It increases the intervillous blood flow 77% in the preeclampsia and without decrease in the maternal blood pressure or fetal heart rate abnormalities. And most of important advantage of labor epidural anesthesia, it provides the route of rapid initiation of anesthesia. You may easily go for emergency LSCS. If the surgeon says that we have to take up the patient, then you can easily go for it. So it is preferred in the severely preeclamptic patient in a non-urgent setting. For urgent cases, we can use spinal anesthesia also. Now, what are the benefits? It provides the pain relief is superior. It attenuates the hypertensive responses to pain. It reduces circulating levels of catecholamines and improves intervillous blood flow, and it provides stable cardiac output. Now, in preeclamptic patients, they are at increased risk of LSCS, so epidural anesthesia or analgesia can be used for emergency LSCS in the doses of 10 ml of 0.25% bupivacaine, and for analgesia, and for anesthesia, we use 0.5 to 0.75% bupivacaine in this patient. Now, the role of spinal anesthesia. It is also a very good technique. It can be used in severe preeclampsia, and we can use bupivacaine, and we can add opioids with this drug. The advantages are that we avoid the risk of general anesthesia. There is elimination of the risk of severe hypertensive response or to laryngoscopy and intubation in general anesthesia. The anesthesia is reliable even with epidural, and as we use small size needle, so there are less chances of any hematoma formation. As we know that the T4 sensory level is required, and we use bupivacaine for this, we get desired T4 sensory level, and at least 2 hours of anesthesia, we get intense anesthesia. If there is fall in systolic blood pressure more than 30% from the pre-block level, then you can use left uterine displacement, and you can increase the rate of fluid infusion. Plus, you use vasopressors like ephedrine in the 5 milligram in increment doses or phenylephrine. Now, what are the precautions you should take while putting the renal blocks? These are that we have discussed that you should check for platelet counts. There is no lowest safe limit for the platelet count. Any clinical evidence of DIC, then you should not give renal block. If the platelet count is more than 1 lakh, you can easily use any renal block. And bleeding time is discarded as an indicator of epidural bleeding risk, as it is not a specific measure of platelet function. So it can be abnormal in many other coagulation disorders like factor deficiencies. So if you doubt that the patient may have a coagulation disorder, go for platelet count. If you are not satisfied, then you can go for platelet prothrombin time, PTTK, it should be done. Now, coming on to the general anesthesia, you have to be prepared for giving general anesthesia to this patient. However, the indications are that if the patient refuses for regional anesthesia, or the patient is coagulopathic, or when there is hemorrhage or sepsis, and the indication is emergency LSCS, in the presence of fetal distress, always monitor for fetal heart rate continuously while placing the block or preparing the patient for anesthesia. Before induction, always restore intravascular fluid volume and control blood pressure. You can induce your patient with either propofol, etomidate, or thiopentone plus succinylcholine to facilitate tracheal intubation. The defasciculating dose of NDMR is not required in these patients, as the patient is already having magnesium therapy, and it attenuates the fasciculation produced by the succinylcholine. Always plan for small size endotracheal tube because of the risk of airway or laryngeal edema. There is a systemic blood pressure response to direct laryngoscopy, which can be overcome by the short duration laryngoscopy. And short duration laryngoscopy, it is the most predictable method of minimizing the magnitude, severity, and duration of blood pressure and heart rate responses that are evoked by the tracheal intubation. So we should always do a short duration laryngoscopy and intubation for a period of less than 15 seconds. If short duration laryngoscopy, it is the most predictable method. And you can also use the drugs also like hydralazine, labetalol or anti-G, which can be administered to attenuate these responses. Always use low doses of volatile anesthetic with or without nitrous oxide, and it can be used for maintenance of anesthesia. In this population, the major determinant of neonatal depression is the prolonged interval between the uterine incision and delivery. So with the duration of anesthesia, it's the most important. Only with the prolonged duration of administration to more than 20% prior to delivery. After delivery, the anesthesia is typically supplemented with opioids. The magnesium which is the patient is taking, there is potentiation of muscle relaxants. So always use peripheral nerve stimulator if you have this facility in your setup. As we have discussed that there are chances of airway edema. So always re-examine the patient, and the edema may appear or worsen at any time during the course of the disease. Look for tongue, facial as well as laryngeal edema. The laryngoscopy and intubation, they cause severe rise in blood pressure. As we have discussed that you can use labetalol, anti-G, esmolol, fentanyl, L-fentanyl in their respective different doses. You have to be cautious with magnesium sulfate because it potentiates both your depolarizing and non-depolarizing drugs, muscle relaxants. So these patients may land into intensive care unit also. Most of the ICU admissions are after the delivery of the baby. However, if the delivery has not occurred and patient is still waiting for the delivery, the management should be directed to obtain a safe blood pressure. That is, you should keep the mean arterial pressure between 105 to 125, control any convulsions, protect the airway and the delivery of the fetus. The women who have severe preeclampsia or eclampsia, they generally come to intensive care unit for IV management of the magnesium and drugs to lower the blood pressure for the hypertension and for the prevention of seizures. If the patient has kidney failure or the fluid in lung, she may need a ICU care. The nursing as the medical staff should be very vigilant, and they should ensure the control of blood pressure and reduce the chances of seizures. Monitor these patients closely for blood pressure. Put a urinary catheter so as to look for any oliguria developing and to monitor the urine output. Mother's blood and urine is tested to check the liver and kidney functions. Look for hemolysis or red cell destruction. These patients, they generally leave the intensive care after their blood pressure comes down or when she no longer requires a magnesium infusion. Now, next comes the eclampsia. It's also very important, and we have discussed as early in the early part of this presentation that it is defined as the convulsions and coma, which is not caused by the coincidental neurological disease occurring during pregnancy and in the postpartum period in the patient who also meets the criteria of the preeclampsia. Most of the seizures, as you know, they are intrapartum or after the or in the first 48 hours of the delivery of the baby. In the late eclampsia definition, there comes the after the 48 hours to 4 weeks postpartum. Now, what are the risk factors of this problem? The young age, nulliparity, multiple gestation, and molar pregnancy, or if the patient is having chronic hypertension. The complications are many. Patient may aspirate, patient may have pulmonary edema, patient may have a risk of stroke or venous thromboembolism. In the fetus, there is growth retardation, prematurity, and placental abruption. Now, there are many pre-monitoring neurological symptoms in these patients. Most of the patients, they have headache, visual disturbances, photophobia, they complain of scotoma, right upper quadrant pain or epigastric pain, and hyperreflexia is there. The seizures are mainly, they start as a facial twitching and they progress to a typical chronic tonic-clonic seizure. The mechanism of these seizure is the loss of normal cerebral regulation, autoregulation, which resulting in the internal or vasogenic cerebral edema and interstitial and vasogenic cerebral edema and decreased cerebral blood flow. Now, how will you manage? The obstetric management aims to the stopping conversion to establish the airway and prevent complications of hypoxemia and aspiration. In the as an anesthesiologist, you have to do a thorough pre-anesthetic assessment should be done, assess for seizure control, maintain fluid balance, control blood pressure, continuously monitor pulse oximetry and fetal heart rate, and lab investigations. Now, as you know that seizures are very short-lived, the anesthetic plan should be tailor-made with the IV induction of propofol thiopentone. Because both these drugs, they reduce the cerebral metabolic rate, cerebral blood flow, and intracranial pressure. You can consider doing hyperventilation in these patients, but with caution. Always avoid aggressive and sudden fall in blood pressure, because you know that the cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. If you allow the fall in mean arterial pressure, the cerebral perfusion pressure will fall and will lead to cerebral edema and other complications. Always avoid hypoxia, hyperthermia, hyperglycemia, because they all add to the neuronal injury. For seizure control, in the previous time, we used to give diazepam in the doses of 5 to 10 milligram. If you have this in your setup, you can use it, but always look for excessive sedation and marked respiratory deprivation, which can occur with diazepam. Now, coming on to the take-home message. What is the take-home message? That preeclampsia, it is a serious multi-organ system disorder of the pregnancy, and it continuously defies our complete understanding. It is characterized by global endothelial cell dysfunction. The cause is still unknown. There is no effective prophylaxis. Delivery is the only effective cure. And we have to control and to prevent breast eclampsia, we have magnesium sulfate with us. We can use for labor pain, you can use epidural analgesia. For emergency LACS, you can convert this analgesia into epidural anesthesia also. If there is dire emergency, you can use general anesthesia for rapid delivery. If the patient has coagulation problem, or there is maternal hemorrhage, or there is fetal distress, you can go for general anesthesia, and it itself has its own risk and benefits. Ensure, as an anesthetist, you should always ensure the optimal management of renal function, intravascular volume, look for airway, and exaggerated pressure response which arises from general anesthesia. So you have to be very cautious, you have to be vigilant, you have to be meticulous enough to manage these patients. As these patients, they pose very dire effects on mother as well as the child. Thank you. Thank you.
Thank you, madam.
Thank you.
I think you have very well covered all of the pathophysiology, the clinical aspect of anesthetic management. What should be your strategy according to the physiological changes and organ involvement in this patient. So now we can discuss with the questions before going to second session. I want to say that when I was resident, I was very worried with the things. When I go to consultant, he says, give spine. And when I go to another consultant, he says, give epidural. And when I go to third consultant, it says, give G. I think things has not changed a lot even till now after 25 years of my learning of anesthesia. Because in anesthesia, we have only 4 bullets. Any type of surgery, any type of patient, one is the regional anesthesia, that is spinal or epidural. But when you have given a spinal and there occur failure of spinal, and surgeon has to do the surgery because of fetal distress. What we give? We give general anesthesia.
Yes.
Because we have avoided general anesthesia because of few concerns. So thing is that if my 4 bullets means spinal, epidural, GA with tube, GA with LMA, GA with mask. So whatever you want to practice, it should be the suitable to your patient, that patient is safely can have a surgery. One thing. There are 3 things. One is the patient. Patient with lot of comorbidities, patient with like this pregnant patient who is having like severe PIH, they can have different organ involvement, cardiorespiratory, neurological involvement if eclampsia occur. And our main aim here, we have to keep mother safe and we have to deliver baby. So one thing is that the bullet we have choose, it should not fail. Means the spinal, if I choose, it should not get failed. It should not have bradycardia, hypotension, high spinal, total. Okay. But if you have chosen epidural, it should not be a high or total spinal. A total spinal is a complication of epidural. We should avoid hematoma because there is no ego issue. There is no ego issue that I will do epidural and I got fight with the surgeons, because our aim should be a joint aim that what we want to have. So technically I should be very solid that technique I choose with pro and cons, with advantages and disadvantages. It should be a very good skill. Means if I choose a spinal, it should be a focused, sure short spinal. If I choose an epidural, it should be a sure short, faster epidural. It's not a patchy effect, so that we have to change technique. And if I have choose a GA, then I should have a valid reason why we can't give the regional and why we have to give safe, how we have to give safe general anesthesia in pregnant women. Because worldwide, if we see, the most common complication of anesthesia and death due to anesthesia are in this group, pregnant females. And that's why we have to be very cautious. We have to consult with our surgeon, what is the status of patient, what is the status of baby. And we have to take care patient problem, the surgery for which patient is waiting, either it is cesarean delivery or any other surgery. And third thing is the anesthesia and anesthetist. How much experience I have in that technique. How routinely I practice, that you have to say in your exam. What is your institutional practice? What is your hospital practice for that type of case? It means you will not say wonder drugs or wonder technique that you have learned just newly and you are not practicing in exam. So I would like to invite Dr. Kushwaha to say a few words or any observation or comments. Dr. Kushwaha, because he is also, there are few questions that came in
video
box.
I'm not able to on my video. It was
your voice is there, boss. We need your voice.
Okay.
So you can add on whatever.
Yes. Madam presented very well and very elaborated. I think all the residents have learned a lot and how to manage. They can enough knowledge Madam has provided.
Thank you, sir.
Thank you, sir.
Thank you, sir.
So,
thank you, ma'am.
Yeah. So only thing is that mild PIH with platelet count more than 50,000, 50 to 60 is enough to give this spinal anesthesia in this group of patients. Severe PIH, you can, if you can control hypotension or high block, that has been also spinally safe in severe PIH. If you are well versed in epidural and you practice that, then epidural can be given if the platelet is more than 60 to 70,000. NR is less than 1.5. And we should not practice skill while learning in this group of patients, in fetal distress patient, in high risk patient. This anesthesia to be given by the senior most resident, because failure are increases with first year or second year as compared to third year. Because when the once complication occur, failure occur, then you will give G. And these patients are very prone for high risk airway, hypoxic death, and fetal death can occur because of hypoxia, hypotension, or any arrhythmia. So our aim is safe patient. Safe patient, we are safe. No ego. If you want to be safe, have your surgeon in belief, because that will be your backup when you have complication or any mortality in patient. Ego should not come in patient way. Thank you. Dr. Indulata, do you want to add something?
Actually,
Yes, is it?
This group of patient is already compromised due to various complications. As ma'am already said, that it is a multi-organ dysfunction occurs in this hypertension in pregnancy. So she very well described all aspects of hypertension in pregnancy very well, and it is very essential to take care of these patients to prevent the maternal mortality, especially in our India. It is very high due to hypertension in pregnancy. So it is very essential to give proper care and proper anesthesia by any means, but with safety. So anesthesia should be chosen by the anesthetist in a very safe manner. So that is all I want to say. And
last thing, that one question: if after giving spinal, if somebody has seizure, the seizure means the patient PIH is now eclampsia.
Yes.
And if you have chosen spinal, now after that seizure occur, the choice is not give antiepileptic. You have to take care on the basis of airway, breathing and circulation. Take care of airway first. Think of breathing. When ventilation, provide adequate oxygenation, because cerebral hypoxia will lead into persistent eclampsia. And you have to intubate this patient because airway secure and ventilation need a definitive airway. Then you take care of hypotension or hypertension or cardiovascular other instability or arrhythmia. And then comes the role of antiepileptic, and your surgeon will start magnesium, and you can start very well the other antiepileptics discussed today. So now we are ending with this preeclampsia, and we are switching over to obstetric emergency. I request Professor Shahla Halim Madam. Professor Shahla Halim Madam is there? So please make co-host to Professor Shahla Halim Madam. Madam is a professor and ex-HOD and chairman of Jawaharlal Nehru Medical College, AMU, and she is teaching for last 8 and 9 years this topic obstetrics in our Spark or postgraduate assembly we are doing for last 9 years. So she is joined. Madam, please share your slides. Yeah, ma'am, we are seeing your laptop screen, but you have to open first your presentation. अपना presentation PPT खोलिए पहले. मैम पहले अपना PPT खोल लीजिए अपने कंप्यूटर पे, उसके बाद शेयर करिए. मैंने. हाँ, हम आपकी स्लाइड्स देख रहे हैं. अरे स्लाइड्स नहीं आई हैं आपकी. अपनी स्लाइड्स खोल के बड़ी कर लीजिए, फिर उसको शेयर करेंगे. जब तक कोई क्वेश्चन अगर किसी को, जब तक स्लाइड्स मैडम ऑन कर रही है. मैडम पीपीटी आपने खोल लिया?
पीपीटी तो खुला हुआ है मेरा।
अब आपका जूम पे हमने आपको कोर्स बनाया, तो शेयर स्क्रीन पे क्लिक करिए। शेयर स्क्रीन पे करेंगे तो आपको फिर पीपीटी उसमें दिखेगा। स्क्रीन आपकी डेस्कटॉप या लैपटॉप हमें शेयर करना है। बढ़िया बढ़िया। अब इसको आप बड़ा कर लीजिए, फुल प्रेजेंटेशन मोड पे कर लीजिए। जी मैम, आप भी दिख रही है कैमरे में, और इसको बहुत बढ़िया। हाँ, इसको फुल कर लीजिए। गुड। अब आप शुरू कर सकते हैं जी।
Okay. Good afternoon and welcome to all PGs who are here for the refresher course 2021. Now I will discuss the topic static emergency. What is an emergency? First, the question arises. Emergency is an acute serious event which develop suddenly and often dangerous in nature and can have a catastrophic consequences which require immediate attention to save life. Generally, it is a difficult situation to manage, and these parturients, they are considered as a high-risk parturients who are for the emergency cesarean section or for emergency management. And we have to consider 2 life rather than 1. And these require, as I told you, immediate attention and protocol-based management to save life. And how to react this emergency? We have to recognize the acute problem and immediately call for help, because it is a multidisciplinary team approach. And always remember the key algorithm for every specific situation, which I have to later on tackle one by one or deal one by one. And always remember that mother comes first. And they are the causes which I have divided into 3 groups: antepartum causes, postpartum, and other causes in which other broad group. So in the antepartum, the hemorrhage, emergency cesarean section, category 1 in this comes as a obstetric emergency. There are 4 categories. You already might be knowing that this may be urgent, this may be emergent, or may be scheduled or elective. So whenever you are getting the emergency, dire emergency, this is known as a category 1 emergency, which is included as a obstetric emergency. And also the complication of preeclampsia and eclampsia, uterine inversion or rupture, and obstetric trauma. In the postpartum causes, postpartum hemorrhage, in which uterine atony and retained placenta, and postpartum eclampsia. Other causes as amniotic fluid embolism, pulmonary embolism, DIC. In anesthetic causes, they also comes in this broad group of obstetric emergency. Suppose very high spinal, as discussed, has happened and becomes a very dire emergency, critical emergency, or a patient has developed the local anesthetic toxicity, or the patient has developed the anaphylaxis, or even developed the cardiac arrest. So I will discuss one by one. The first is the obstetric hemorrhage, in which it is one of the first most leading cause of death worldwide. In India, the incidence of maternal mortality is very high. Due to hemorrhage, it is about 35 to 56%. Even 2 to 55% deliveries, they are complicated by the PPH. This massive uncontrolled hemorrhage. Why this happen? This is happen because of the, you already have know that it is discussed in very detail, that there is an increase in the cardiac output in the pregnancy. And this increases up to 30 to 50% of the pre-labor value at 32 weeks of pregnancy, and which increases further at about 50 to 80% in second and third stage of labor. And this increase in the tremendous increase in the cardiac output, which causes the rapid gush of the blood to the uterine artery, and then there is a problem because of the atony or because of some placenta accreta, then there is a massive hemorrhage which is sometimes unable to control and heading toward the hysterectomy. And this hemorrhage may be concealed, or you will not be able to get the sign of hypovolemia. So assessment of this patient is very important. How to assess this blood loss during this obstetric patient or even any hemorrhage is that usually you are not getting the sign and symptom of this hemorrhage up to second stage of labor, or when the patient has the blood loss or deficit of up to 30%. Because the patient usually not develop the hypotension, there might be orthostatic hypotension, or you will get only the tachycardia, tachypnea, or narrow pulse pressure. When the deficit is 30 to 40%, then you will get the hypotension. There will be tachycardia, tachypnea, or you might get the oliguria. When the loss is more than 40%, the patient will be in shock, BP may not be recordable, patient may be having an altered consciousness, or you might get the anuria. Why this happen? This happen because the compensatory mechanism of the body usually try to work when there is a decrease in the blood pressure and decrease in the cardiac output. There is a simultaneously decrease in the systemic vascular resistance. So there is, when there is a decreased BP, there is increased systemic vascular resistance, and up to 40% of the decrease in the blood pressure or cardiac output, systemic vascular resistance increases to highest level, and so compensatory mechanism act up to this, and then it comes the plateau phase. So you will get the sudden or unrecordable BP after this 40% of the loss. So this type of hemorrhage, you know that the antepartum and postpartum. Postpartum usually when the loss occur within 24 hours of the delivery. It may be usually the late pregnancy. It may be placenta previa or abruption or DIC, or even the due to amniotic fluid embolism or trauma. In the postpartum causes, maybe uterine atony or surgical trauma or retained placenta. So what is placenta previa? When the placenta implant in the advance of the fetal presenting part. It is usually the incidence is 1 in 200 pregnancy. It may be total placenta previa, partial placenta previa, or marginal. When the placenta covers the entire cervical os, it is a total placenta previa. So it is a more dangerous situation as compared to the total or partial or marginal. This placenta previa may be 3 types, may be associated with the placenta accreta, increta, or percreta. The characteristic is that the bleeding in the usually in the placenta previa is painless, and it occurs after this 32 week of gestation. This may be when the placenta adherent to the myometrium, it is placenta accreta. When it is invaded to the myometrium, this is increta. When it invaded to the uterine serosa or other pelvic structure, it is the percreta. The double setup examination is required for this, and which is an emergency procedure. It is done usually in the operation theater. So whenever this is planned, the double setup examination is planned, you have always prepare for the cesarean section. The prerequisite or preparation includes you have to attach all the monitor when you take the patient in the OT. You have to monitor, attach the monitor to know the baseline vital parameters of the patient. Insert the 2 large gauge IV cannulae, and if preferably 14 or 16 gauge cannula, one should be 14 or 16 gauge. You have to give the anti-aspiration prophylaxis also because it is an emergency. And you have to take all the aseptic precaution. And after taking this sterilization and preparation and draping of the abdomen, and you have to arrange for the blood and blood product, especially the PRBC, to be arranged, and blood has to be sent for the cross matching. And what should be the choice of anesthetic for this patient? It depends upon the indication and urgency, and also the degree of hypovolemia. Because it happens that usually there is a high risk of intraoperative blood loss. Or suppose you have taken the patient under regional anesthesia and patient developed the atonic PPS during the management of this patient, you should always convert the regional into the GA, because every patient, critical patient, and you have to provide the good oxygenation, ventilation, and circulatory status of the patient. So you will get the good neurological outcome, as told by Dr. Sandeep, that it is the mandatory thing for the management of any patient. So how will you proceed for the management of this patient? So you have to evaluate your patient, the extent of blood loss and hemorrhage, resuscitate accordingly. You have to resuscitate your patient and prepare for the operative delivery. The assessment of the airway is very important thing. So you have to take the precautionary measure and do all the preparation, including the difficult airway cart and arrangement of small size tube. So you have to keep ready everything with and also the supraglottic devices. You have to assess the intravascular volume deficit, and so you can give the aggressive fluid replacement. And along with this, you have to evaluate the maternal hemodynamics and fetal heart rate monitoring to be done prior to taking the patient, and also fetal tachography to be done. And so in the preparation, you have to maintain the supplemental oxygen. Along with this, left uterine displacement to be done to prevent the aortic cable compression. So in examination, whenever you are getting the patient, suppose placenta previa, and you have to discuss the management, always start with that. You have to provide take the vitals of the patient, maintain the oxygenation by giving the supplemental oxygen, and put the left wedge under the right buttock to provide the left uterine displacement to prevent the aortic cable compression. And it is a method of intrauterine resuscitation. So you have to put already the large IV cannula and arrange the 4 unit of PRBC, coagulation status to be checked, and equipment for invasive monitoring to be ready, and start the invasive monitoring. Or for management, especially, you have to send the blood for the complete blood count, for thrombin time, partial thromboplastin time, and platelet count. The bedside coagulation testing, especially the thromboelastography and thromboelastometry, to be, if there is a facility for this to be done, because it tells about the real clotting status of the patient. Volume status, I told you, should be very aggressive and immediate, and you have to start the crystalloid when you are till you are getting the blood. And when you are considering that the patient have excessive blood loss, then you have to, and PRBC is available, now you start the blood. When the patient having a more than 80% of the blood volume is replaced, always suspect that patient is heading toward the dilutional coagulopathy or might be having a dilutional coagulopathy. So you have to give the platelet and FFP and cryoprecipitate, so you can be able to correct that. One question arises whether the regional can be given to this patient, patient who is hemodynamically stable. So regional only be the in this condition that the patient is hemodynamically stable and there is no history of recent bleeding, and patient is for cesarean delivery, elective cesarean delivery. And for the emergency cesarean delivery and patient is bleeding or history of bleeding, then you never give the regional anesthesia, because it is a good big question on the part of the anesthesiologist who is attending the patient. So it is that only when there is no history of bleeding and it is elective and patient is hemodynamically stable, you can give the low dose of this regional anesthesia can be planned. Usually the general anesthesia is a choice. You have to follow the rapid sequence induction, and propofol should not be given in a hypovolemic patient. You might be knowing. Ketamine in the dose 0.5 to 1 milligram per kg to be given, should not be more than 1 milligram per kg. And etomidate in the dose of 0.3 milligram per kg, it also a good choice for bleeding patient. Suppose the patient with the having a severe hypovolemia and patient having an altered sensorium, then you can give the crash intubation with the help of muscle relaxant. This patient usually require the management in the high dependency. Placenta accreta, usually hemorrhage, here is very massive hemorrhage occur when the removal of placenta is attempted after the delivery. And this placenta accreta needs the thorough and also the planned very meticulous delivery management. So because the management required the close coordination among the anesthesiologist, obstetrician, interventional radiologist, and blood bank, a specialized surgical team. Elective cesarean at 34 weeks usually done to avoid the emergency delivery. Sometimes there may be chances that the patient may develop the serious hemorrhage and may require the hysterectomy. Usually it happens. Now with the advances in the endovascular procedure or where there is a rheological good suit, they can be offered this endovascular procedure in some selected cases. And usually the diagnosis usually made intraoperatively and massive transfusion protocol to be followed. And what is this massive transfusion protocol? In the placenta accreta especially, where the blood bank has to release the 6 unit of O negative PRBC and 4 unit of ABFFP. And then within this 20 minutes of this release, they have to release the another additional 10 units of PRBC and 10 unit of FFP and 10 unit of platelet and 10 unit of cryoprecipitate. Then there is whether there is a role of autologous cell salvage. It is usually not tried in this obstetric patient because of the risk of amniotic fluid embolism and maternal alloembolization. So it is not done. What is this damage control resuscitation? It is usually done to decrease the intraoperative crystalloid and colloid to manage the patient with the help of crystalloid and crystalloid. And initially, and the PRBC and FFP and platelet usually given in the ratio of 1:1:1 to avoid the development of dilutional coagulopathy. So when the question is asked, what is damage control resuscitation? It is a where the blood and blood product in the ratio of 1:1 means PRBC, FFP and platelet is given to avoid the development of dilutional coagulopathy. Cryoprecipitate and the antifibrinolytic, they are usually given when there is a FFP and RBC ratio is very high. Usually early administration of cryoprecipitate in the dose of 3 milligram per kg is enough to raise the fibrinogen level of by 1 gram per liter. Then comes the postpartum hemorrhage. The incidence is also in the developing country is 1 in 1,000 delivery. And postpartum hemorrhage, it is dealt very detailed and nicely by Dr. Usha Shukla. That's primary and secondary. This PPH. No, eclampsia. So postpartum hemorrhage, primary and secondary PPH. Primary is, you know, that it is because of the within 24 hours, because of the atonia or because of sudden placenta previa or hemorrhage. And the postpartum usually after 24 hours, within 24 hours to 6 weeks. So usually the etiology, it is a 4 etiology of primary PPH. Uterine atonia is in most of the cases, 90% is the cause of the PPH, and other causes as the tissue because of the retained product, and because of the placenta previa or abruptio placentae, or maybe because of trauma, genital tract, or because of the abnormality of coagulation as coagulopathy. So the role of uterotonic is especially should always be considered in these patients. Oxytocin in the dose of 20 to 40 unit in 1 liter of normal saline to be started immediately at the time of delivery. And this oxytocin should not be given very rapidly if the patient is having a hypotension, and because the side effect is that it can lead to the tachycardia and dysarrhythmias. Methergine 0.2 milligram intramuscular or intramyometric can be given. It may lead to the severe hypertension in the normal patient, using normotensive patient, so it is usually avoided. But it used in the, especially in the bleeding patient, it may lead to the coronary spasm, dysarrhythmias. Misoprostol or the prostaglandin E analog, it is used rectally, orally, or sublingually. Dose is 800 microgram. This causes the bronchoconstriction. Prostaglandin F2 alpha, it is given in the dose of 1000 microgram rectally or sublingually. It increases the pulmonary artery pressure and lead to the bronchospasm. So whenever you are giving the patient these to the asthmatic patient, you always think may lead to the severe bronchospasm to these patients. Or even the carboprost, it also lead to the bronchospasm, but it is used in the cases of the refractory uterine atony in the dose of 250 microgram. Hemostatic as tranexamic acid, it is given in the dose of 1 gram IV stat, and second dose is given after 30 minutes. Then it is given as a infusion of 1 gram per hour over 6 hours. Recombinant factor 7 or NOVO7, it is usually used as a rescue therapy in unresponsive hemorrhage. The cost is very high, and there is a prerequisite for administration of this NOVO7 is that the patient should have a platelet count of more than 50,000. The fibrinogen level should be more than 0.5 gram per liter, and pH should be more than 7.2. And means your patient should not be in metabolic acidosis whenever you are giving this to the patient. And dose is 90 microgram per kg stat followed by 120 microgram per kg. But the cost is very high with this, and there is risk of thromboembolic event. There is also this Bakri balloon. It is a term is used by the obstetrician. So you have to just knowledge, because it is used for the uterine compression, and where the provide the hydrostatic uterine balloon tamponade, where the balloon is put into the uterine cavity and inflated with the 300 to 500 ml of saline and leave in place for 24 hours. Other surgical technique as uterine compression suture, as Billin suture, and other hemostatic suture technique. There is a devascularization procedure as bilateral uterine artery ligation, bilateral internal iliac artery ligation, or arterial embolization. There is also the hysterectomy is indicated sometime when there is a uterine atony or placenta accreta, or even in cases of uterine rupture. For the radiological management, as I told you, where the patient, when the mother is stable and she has to be transferred to the radiological suite, where the radiologist, they identify the vessel which is bleeding, and they embolize the bleeding vessel under local anesthesia. Angiographic occlusion of the balloon catheter, it is where the balloon is placed in the hypogastric or common iliac arteries, and which having a temporizing measure. So in nutshell, how will you proceed? When you get the call, you have to call for help, because it is a team approach. You have to assess the airway, breathing and circulation, stabilize the circulation, provide the patent airway, good oxygenation and ventilation, and provide supplementary oxygen by and left uterine displacement, obtain the wide bore IV line, start the IV fluid with the crystalloid, monitor the vital sign of the patient, catheterize the bladder, so you will be able to know the urine output, assess the need for transfusion, and arrange blood and blood product, and blood to be sent for the CBC coagulation status and the blood group. Next comes the uterine rupture. This is also a dire emergency, a serious emergency, where the resuscitation of mother is required. There is a urgent laparotomy and urgent delivery of the baby, and done under the general anesthesia, because of the massive hemorrhage and rapid decompensation of the mother. So management of blood loss and needs a invasive monitoring, especially the RTL line and CVP line to be put to know the beat to beat variation in the BP. Then management of uterine inversion is also an emergency, and they have to immediately replace the inverted uterus, and so rapid uterine relaxation is required, and which having a no residual anesthetic effect. It can be done under the nitroglycerin IV, 50 to 200 microgram can be used, or you with this sometimes there is a decrease in the BP, so you have to support the circulation with the IV fluid and the use of the vasopressor, usually the ephedrine 5 to 10 milligram or phenylephrine 100 microgram. Usually GA with the inhalational agent is the most preferred agent. And this emergency cesarean, because it is, I told you, category 1 emergency cesarean section, which is where there is a immediate threat to the life of mother and the fetus. It can be emergency section, as I told you, it can be performed under axial anesthesia or general anesthesia, spinal, epidural, CSE, or continuous spinal. But whatever the technique you have to follow, this should be well versed. The spinal anesthesia, usually it is preferred technique, and because of the airway problem, because of the aspiration pneumonitis which happened in the past, and difficult intubation. So fetal distress or patient having a sudden prolapse, hand prolapse or bra presentation, or any indication for the emergency cesarean section, then it can be given because you have to manage the circulation or provide the hemodynamic stability with the general anesthesia. Platelet taking these agents, and you have to perform the guideline is that you have to give the unfractionated heparin. If the patient has taken, then removal of epidural catheter should occur 1 hour prior, and neuraxial anesthesia should not be performed if the patient has received the fibrinolytic or thrombolytic therapy. The general anesthesia, you have to give the start the oxygen and put it in the patient in the left lateral tilt has to be provided, and give the anti-aspiration prophylaxis, and also arrange the equipment for the failed intubation and status of the patient, and relax with the succinylcholine, oxytocin 5 units slow IV, and put in the drip 40 units. Preeclampsia, I told previously that Dr. Usha Shukla has already covered in detail and very nicely. So it is also because it is a complication of this eclampsia or preeclampsia we are getting in the as a dire emergency. And this is the one of the third leading cause of the pregnancy related death, superseded by hemorrhage and embolism. So prognosis is poor, and whenever eclampsia seizure is superimposed on preeclampsia, it is eclampsia. You know that what are the challenges whenever you are getting the patient of the eclampsia, because there is a risk of maternal mortality is very high, 1 in 50 women, and 23% of these patients, they require the ventilation and management in ICU. 35% may be associated with the risk of pulmonary edema or hepatorenal failure or renal failure. They might be having a DIC or hemolysis, elevated liver enzyme and low platelet count, or they may be having an acute respiratory distress syndrome. There may be intracranial hemorrhage, or they may develop the sudden cardiac arrest. There is also the risk of neonatal death in 1 to 14 cases of eclampsia. So there are some danger signs of eclampsia and eclampsia. What is this? When the BP is more than 180 or 200 and diastolic is more than 120, and these are usually, these patients usually develop the encephalopathy. It is a hypertensive encephalopathy, and they might be having an intracranial hemorrhage. Or if they examine, they might be having a retinal exudate or hemorrhage, and there will be papilledema. These patients having a pulmonary edema and uteroplacental hyperperfusion sometime, and placental abruption or hemorrhage. So whenever you are getting the patient of this preeclampsia with the high proteinuria, means 3+ and double of the AST, and urine protein creatine ratio of more than 30, means we are thinking that the patients are not developing the complication of preeclampsia. And there is also one criteria. This is a Eden criteria. Whenever this is present, it is considered as severe eclampsia. What is this? The coma of 6 or more hours, temperature of 39 degrees or more, pulse is over 120 per minute, systolic blood pressure is over 200 mmHg, respiratory rate of more than 40 per minute, and patient having a more than 10 convulsions. So these are the patients, these are the very high risk patients. So what is the aim of management? First, you have to ensure the maternal and fetal well-being. Then you have to provide the patent airway, you have to prevent and control the convulsion, control the blood pressure of the patient, and you have to manage the fluid and deliver the fetus. You have to provide the effective postpartum care and manage the complication of this problem. So how will you approach? You immediately call for help, because I told you this is one of the dire emergency, and secure the airway and provide the high flow of oxygen to this patient, putting the wedge under the right hip, secure the intravenous line, and send the blood for the hematological screening, FFB and platelet and everything, and ask for the blood and blood product and cross matching, control the convulsion by the help of diazepam or thiopentone, and control the hypertension by the hydralazine or lobetalol IV. Infusion of sodium nitroproside can also be given. For the convulsion, control of the convulsion, magnesium sulfate is the choice, but immediately you have to, you can control by giving the diazepam or midazolam or thiopentone, as I told you. For the blood pressure control, the IV hydralazine, usually it is given as a 5 milligrams, so slow IV bolus, and you have to titrate the dose by getting the response, and you can increase up to 10 or up to 15 to 20 milligram. then lobetalol, but there is a chances of this tachycardia and neonatal thrombocytopenia. Lobetalol in the dose of 10 milligrams flow IV bolus usually started, and it is checked every 5 to 10 minutes. You can increase the dose till you get the desired response. Fluids usually given a very titrated dose as 1 to 2 ml per kg per hour, and with the urine output monitoring. Diazepam could be also you can give. I told you magnesium sulfate, what should be the dose? It is already told about this. That is 4 to 6 gram given slow IV bolus over 5 to 10 minutes. Then 1 to 2 gram per hour as a infusion. And you have to monitor the patellar reflex. When there is a loss of patellar reflex, or when there is a respiratory depression, or when there is the urine output, 3 things you have to measure with the magnesium sulfate. Another regime is that you can give the magnesium sulfate as 5 gram in each buttock of 50% solution. Phenytoin and the sodium thiopentone, as I told you, this can also be. It is found that there is a MAGPIE trial, and they have found that when the magnesium sulfate is given as a seizure prophylaxis, it decreases the incidence of eclampsia up to 59%. And there is also decrease in the chances of abruption up to 36%. And even the maternal death is also reduced up to 46%. So it should be given, and should know that it is available as 2 ml ampule in the 50% solution. So you have to take the 4 ampule of this, and you have to make it up to 20 ml with 5% dextrose and given over 10 minutes. Whenever you are getting any sign of this loss of patellar reflex or respiratory depression, or even with the ECG changes, then immediately stop the magnesium sulfate, and you have to against this magnesium toxicity, you have to give the calcium gluconate 10 ml of 10% solution by slow IV injection to counteract the effect of magnesium sulfate. One thing also you have to remember always that magnesium sulfate crosses the placenta and can lead to fetal hypotonia and respiratory depression. So how will you take this patient? The assessment of fluid and fluid balance. As I told you, you have to give the fluid in the dose of 1 to 2 ml per kg, because this patient having a hypoalbuminemia, and there is an increased risk of capillary, there is increased capillary permeability, and they have a leaky capillaries. So there is risk of pulmonary edema. Assessment of renal, hepatic, and CNS function to be done, and airway, because the patient having airway changes. So you have to also always keep in mind, assess the coagulation status and assess the hematological status of the patient and arrange accordingly. As I told you, it is found that the dexamethasone also increases the platelet count. So you can also give if the patient having a low platelet count, and you have think in the mind. Then there is a question whether the spinal anesthesia can be used in the severe preeclampsia, severe preeclampsia. Then according to the Nelson and Angelo, there should be an aggressive approach to provide the regional anesthesia and patient with a severe preeclampsia, and should always be considered in an attempt to reduce the overall risk. So patient has not developed the convulsion, and patient is having a 160 BP, 160 by 90 BP, or patient is stable. You can think about the low dose spinal with opioid, and you can plan this. What are the can spinal be? So when the patient also having no coagulopathy, you always be concerned over the coagulopathy, and you have seen the clotting screen, and the clotting screen is also the normal. Then you can give the regional. Because early epidural is an ideal for the pain relief in preeclamptic patient, and it provides the smooth control of BP and maintain the uteroplacental perfusion. GA, as I told you, the anti-aspiration prophylaxis, pre-oxygenation, rapid control of BP, and you have to attenuate the pressure response to laryngoscopy and intubation. Also important thing in the preeclampsia, severe preeclampsia and eclampsia. And for this, you can use the hydralazine, the dose of 5 to 10 milligram. It should be given at least 20 minutes prior to induction. And lobetalol also in the dose of 10 to 20 milligram, 10 minutes prior to induction can be a good choice. Esmolol is also can in the dose of 0.3 to 0.5 milligram per kg can be used as a bolus prior to induction to attenuate the pressure response to laryngoscopy and intubation in the severe preeclampsia and eclampsia. Lidocaine is always a good choice. It should be given in the dose of 1.5 to 2 milligram per kg during induction. Always anticipate difficult airway and arrange difficult airway cart and small size tube. RSI and intubation after the assessment of mask ventilation to be done. And this you have to ensure the proper depth of anesthesia by the inhalational supplement of inhalational agent, and neuromuscular monitoring to be done. Why? Because the magnesium sulfate potentiate the depolarizing and the non-depolarizing muscle relaxation. There is also with the magnesium sulfate, there is chances of uterine atony. So always take care of this carbopast and misoprost along with this oxytocin. In the patient, if the patient of the myasthenia gravis, magnesium sulfate is contraindicated, and also magnesium sulfate to be used cautiously when the patient is on the calcium channel blocker, because it produces the hypotension. And this magnesium sulfate to be continued in the post-operative period, 24 hours. So if you are getting the eclamptic patient, what will be? If the patient having a normal ICP, no clinical evidence of bleeding, maintenance of platelet more than 80,000 per cubic millimeter, you can consider the regional anesthesia. It is a good choice. If the patient has raised ICP, clinical evidence of bleeding, and there is a decrease in the platelet less than 80,000 per cubic millimeter, you avoid the regional and consider the GA. And there is a ABC of eclampsia, which was also tell about the before by Dr. Sandeep. You have to take care of airway, and by left side turn to the patient, and also bag mask ventilation, maintain the airway, patent airway, provide the oxygenation and ventilation, and provide the stable circulatory status, and manage with the drug, especially the magnesium sulfate and antihypertensive agent. Then comes the amniotic fluid embolism. It is the 5th most common cause of maternal mortality in the world, and it is suggested as anaphylactoid syndrome of the pregnancy. And there are 3 major manifestations which are responsible for this syndrome are the acute pulmonary embolism, disseminated intravascular coagulation, and uterine atony. What happened? There is when this fetal tissue part of fetal tissue enter the maternal circulation, there is an activation of inflammatory cascade, and there is a surge of the cytokine and release of the various anti-inflammatory markers, and they lead to the development of sudden vasoconstriction and development of hypoxemia, and leading to the heart failure and hypotension. Also, patient may develop because of the activation of inflammatory cascade, DIC, and bleeding. All these hypotension and bleeding, they all lead to the severe hypoxemia and finally the neurological insult. So how will you manage? You have to manage cause symptoms, a sign and symptom of the this amniotic fluid embolism, because there is a sudden maternal collapse. So you have to resuscitate the cardiovascular and the respiratory system, and take care of the coagulopathy and correct the coagulopathy. Immediate cesarean section usually required for this, and you have to provide the fluid resuscitation, especially the optimize the preload, provide the inotropic support, vasopressors, and under invasive monitoring, you have to manage if the patient has already cesarean section has completed, and the patient should be monitored in the ICU, transferred to the ICU and monitored there. So there is also algorithm ABC of amniotic fluid embolus. You have to call for help of oxygen. Fetal monitoring is important thing. Optimize preload, consider invasive monitoring, give blood and blood product. Also consider the hydrocortisone. There is sepsis. It is also a static emergency. There is a first sepsis 6 protocol for the severe sepsis, and there is a high flow of oxygen to be given to the patient to maintain the oxygen saturation of more than 94%. Blood should be sent for the culture. One should be drawn percutaneously, another from the vascular side. Broad spectrum antibiotic to be given. Fluid in the this. Am I audible?
मैम प्लीज समराइज कीजिए आप समराइज
है
थोड़ा समराइज कीजिए मैम टॉपिक क्योंकि टाइम
You are audible.
अच्छा शॉर्ट कर देती हूँ. Obstetric trauma, it is urgent need for care of the trauma victim. So patient should be managed within golden hour time and within this platinum minute. डॉक्टर संदीप क्या कह रहे हैं?
आपकी स्लाइड शेयर कर लीजिए, दोबारा देख लीजिए.
स्लाइड तो शेयर कर रही हूँ मैं. 3 I am new share. शेयर हो गया?
पोस्ट बनाया है ना उसने. आप फिर से शेयर करिए मैम, क्योंकि शेयर है नहीं. जी आगे देखिए, शेयर स्क्रीन का. मैडम आपको आवाज आ रही है? डॉक्टर शाला आपको आवाज आ रही है क्या? वीडियो तो है, माइक को इनेबल कैसे आपको माइक में ऑन कर लीजिए. आपका माइक ऑफ, आवाज नहीं आ रही. स्लाइड आ रही है? स्लाइड भी नहीं आ रही, आवाज भी नहीं आ रही. दोबारा शेयर कर लीजिए. दोबारा से
शुरू करूं जूम पे. स्लाइड नहीं दिख रही. स्लाइड तो हम कह रहे हैं स्क्रीन शेयरिंग तो कर रहे हैं. फिर से निकाल के करूं.
So we have only few slides left in obstetric emergencies because when you are giving good viva, then viva and in theory question they ask about obstetric emergencies, and after that we will discuss in a half hour mitral stenosis, what is different in this type of pregnant term patient. आपका शेयर हो रहा नहीं हो रहा मैम? सर आपका वीडियो तो आप 1 मिनट रुक जाइए, फिर मैं ऐसा करता हूँ कि माइटल स्टेनोसिस शेयर करिए. So we request Dr. Puneet Khanna from AIMS New Delhi. बॉस आप हैं?
हाँ संदीप, आई थिंक स्टार्ट करते हैं.
हाँ आप प्लीज शुरू करिए.
I'll try sharing the screen. ठीक है. हाँ.
Dr. Puneet Khanna is my very good friend and he's from AIMS New Delhi and he's author of very good scientific material and also so many books like ultrasound for the beginners, and now they are coming with a book for the postgraduate students, long and short cases, and also they have a range of books written for the UGs. So now over to Dr. Puneet Khanna.
Sandeep, I will thank you first of all to giving me a chance. It is always a pleasure to work with you. So I'll try to keep it as I'll try to keep it as short as possible. Last time से slides थोड़े और कम करे हैं, ठीक है? So to begin with the topic, severe mitral stenosis with pregnancy. Myself Puneet. The problem statement. The problem statement is such that ab ki bari, if you look at an issue by heart and lung and circulation, the January issue. The January issue, if you take, the whole of the issue is dedicated on the woman's heart health, the heart disease and the pregnancy, and the need for a 21st century approach to take care of it. Although it might be a 21st century approach, the consensus is the same. The best obstetric and the neonatal outcomes in women with cardiac disease are delivered by a strategy of carefully coordinated multidisciplinary care. So we need everyone, we need a multidisciplinary approach. That was the crux of it. Coming to the topic proper. Etiology. So to take the etiology, MS can be divided into acquired and congenital. Acquired is rheumatic. And if it's a prolonged calcification of the valve, there occurs a calcification. So most of us commonly deal with the mitral stenosis of rheumatic origin. So coming to the pathophysiology, mitral stenosis, the basic pathophysiology lies due to increase in the LA pressure and the LA dilatation. The LA pressure is raised due to pulmonary venous hypertension, pulmonary arterial hypertension. There occurs a right ventricle hypertrophy. Eventually, the right ventricle goes into a failure. LA dilatation leads to atrial fibrillation, and atrial fibrillation, there occurs a stasis of the blood. Due to the stasis of the blood, there occurs a thrombus formation, and the thrombus can dislodge itself, causing systemic embolization. So this time I have skipped basically the clinical features, symptomatology, your inspection, palpation, murmurs, this all I have skipped. I have straight away came to the complications. The most common complications are the atrial dysrhythmias. Systemic embolization occurs in 10 to 25% of the patients. The risk of embolization is related to the age, presence of atrial fibrillation and previous embolic events. Congestive heart failure can occur, pulmonary infarcts can occur, hemoptysis occurs secondary due to the rupture of the bronchial veins due to pulmonary hypertension. There may be streaking pink frothy sputum occurring due to pulmonary edema. Endocarditis can take place, and there is recurrent pulmonary infections. Coming to atrial fibrillation first, 30 to 40% of the patients with symptomatic mitral stenosis develop atrial fibrillation. The structural changes are due to the pressure and the volume overload, which alter the electrophysiological properties of the left atrium. Rheumatic process itself may lead to the fibrosis of the internodal and interarterial tracts, which will damage the nodes. These are the various pathophysiological changes that occur and cause atrial fibrillation. Atrial fibrillation is common in older adults. They carry a poor prognosis. 10-year survival rate of 25% occurs with atrial fibrillation. 46% may survive due to sinus rhythm, if there is sinus rhythm. The risk of arterial embolization or stroke is significantly increased in atrial fibrillation. Coming to ECG, X-ray, and echo. The ECG first. So let's describe what's the axis. Axis basically is the right axis deviation that occurs due to right ventricular hypertrophy. What happens to the P wave? The P waves are broad and bifid in V1, lead 1, and lead 2. There may be an inverted P in lead 3, or there may be an absent P wave. Absence of the P wave may occur in atrial fibrillation. QRS complexes, there is a tall R wave in V1, occurs due to right ventricular hypertrophy. RR interval may be varying due to atrial fibrillation. Chest X-rays, this is a typical standard MBBS question, even asked in MD exams. What happens in chest X-rays? There is straightening of the left heart border. Why does the left heart border straightens? It is due to the prominent pulmonary artery and left atrial appendage. Double shadow behind the heart, a shadow within a shadow occurs due to left atrial enlargement. There is playing of the carinas. Playing of the carina occurs due to left atrial enlargement. Calcification appears over the mitral valve. Then coming to the famous lines, curly ABC lines, curly B lines are the dense, short, horizontal lines in the costophrenic angles, which occurs due to intra-alveolar septal thickening. Curly C lines occur due to the reticular pattern throughout the lungs. Curly A lines, they are straight, dense lines up to 4 centimeters towards the hilum. These are due to the distended lymphatics. There may be pulmonary hemosiderosis, which may be visible as bilateral patchy alveolar infiltrates. On doing a barium swallow, there may be sickling of the barium-filled esophagus due to the compression by the enlarged LA. These are the standard X-ray features that you should know. Echo. 2D echo and Doppler echo is a diagnostic tool of choice. A dilated left atrium, restricted diastolic opening of the mitral valve leaflets, doming of the anterior leaflet, immobility of the posterior leaflet, and planimetry of the orifice in the short axis view has to be done. So these are all the things which we can observe on an echo. So what are the class 1 indications of doing an echocardiography? Diagnosis of mitral stenosis, mean gradient, mitral valve area, pulmonary artery pressures can be observed on echocardiography. You can also look out for a concomitant valve lesion. There may be mitral stenosis associated with tricuspid stenosis, atrial stenosis, etc. You can also comment upon the valve morphology. You can rule out a left atrial thrombus, which if present poses a life-threatening complication. Transesophageal echo may be used when transthoracic echo provides a suboptimal data. Echo is reasonable also in the re-evaluation of asymptomatic patients with MS and stable clinical findings to assess pulmonary pressures. This is a guideline which says severe MS and echo should be done every year. Moderate MS, it should be repeated 1 to 2 years. Mild MS, every 3 to 5 years. Then cardiac catheterization. What are the class 1 indications for cardiac catheterization? to assess the severity when non-invasive tests are inconclusive or there is a discrepancy between the non-invasive and the clinical symptoms, to evaluate the severity of mitral regurgitation when there is discrepancy between the Doppler-derived mean gradient and the valve area. What are the peculiar changes that occur in the pregnant patient predisposition to aggravation of the symptoms in an underlying stenotic lesions? Mitral stenosis के अंदर ऐसा क्या होता है प्रेगनेंसी के दौरान which it becomes very difficult to handle? So let us look at the hemodynamic changes that occur during pregnancy. There is increase in heart rate, there is increase in cardiac output, there is increase in blood volume, and there is decrease in SVR. Parantu, hemodynamic changes or hemodynamic goals that we have to keep in mitral stenosis are totally opposite to the changes that occur during pregnancy. That is, decrease in heart rate, adequate preload and cardiac output, decrease in blood volume, and increase in SVR. So we look like these are exactly opposite to what happens naturally during pregnancy. That's why it becomes a difficult patient to handle. Any valvular lesion should always be described in terms of a cardiac grid. What is a cardiac grid? Cardiac grid basically consists of a preload, SVR, PVR, contractility, heart rate, and rhythm. These are basically our cardiac goals. The preload should be maintained. SVR should be maintained near normal. We should avoid increase in the PVR. Contractility should be maintained towards normal. We should avoid tachycardia and try to maintain a sinus rhythm. Management. Management can be medical, surgical, or obstetrical. Medical management basically consists of diuretics, beta blockers. For controlling atrial fibrillation, digoxin and anticoagulants may be used. Surgically, valvuloplasty or valve replacement. Obstetrically is the delivery of the child either vaginally or cesarean section. Medical therapy, basic medical therapy which is used is like a prophylaxis against rheumatic fever, avoidance of unusual physical stress, rate control in atrial fibrillation. The drugs used are digoxin, beta blockers, and calcium channel blockers. Whenever there is an evidence of pulmonary congestion, we use a salt-restricted diet, diuretics, anticoagulation in the atrial fibrillation, and endocarditis prophylaxis if there is a replacement done. What are the indications? What are the indications for anticoagulation? Class 1 indications are mitral stenosis with atrial fibrillation, mitral stenosis with prior embolic event, even in sinus rhythm, mitral stenosis with a left atrial thrombus. Class 2 indication is symptomatic severe MS with LA dimension greater than 50 millimeter by echo. So how do you manage the anticoagulation? If the patient is on warfarin, you do an initial INR. If the INR is greater than 3, you decrease the dose of the warfarin and bring down the INR to range of 2 to 3. You can stop warfarin in an elective surgery at least 3 to 4 days before the planned surgery. Try to get the INR below 2 before the day of surgery and bridge it with heparin. If the patient is high risk, start heparin after stopping warfarin, and heparin has to be stopped 6 hours prior to performing a section. If the patient is low risk, there is no need to start heparin, and you can start the heparin in the post-op period. If it's an emergency surgery, either you have to reverse warfarin or either you would have to reverse heparin. In an ideal situation, we stop heparin 6 hours before. If a patient comes with a fetal distress and the patient is on warfarin, how will you reverse the effect of warfarin? Give FFP 15 ml per kg Vitamin K, 0.5 to 2 milligram IV, then 10 milligram IM, then 5 milligram fourth hourly. And to reverse heparin, protamine 1 milligram for every 100 units of heparin. Pregnancy and severe MS. So what's the big deal? A pregnant patient will not tolerate hemodynamic burden of pregnancy with severe mitral stenosis. So therefore, should we consider the patient for PBMB before conception? Yes. If a patient is not a candidate for percutaneous mitral valvotomy, we should do a commissurotomy. Or if a valve replacement is indicated, we should place a bioprosthetic valve. Patients who develop NYHA 3 or 4 symptoms during the pregnancy should undergo PBMV with limited fluoroscopy. It takes hardly 1 to 2 minutes exposure with abdominal and pelvic shield and under echo guidance. Management: percutaneous balloon mitral valvotomy may be done, closed surgical commissurotomy may be done, open commissurotomy may be done, or a mitral valve replacement may be done. Who are the candidates for PBMV? Mobile, non-calcified leaflets, no commissural calcification, and little subvalvular fusion. Or a Wilkins course can be done, which has 4 grades in each: mobility, subvalvular thickening, valve thickening, and calcification. The main focus will lie if it is non-calcified, the commissures are non-calcified, and there is little subvalvular fusion. Mitral valve repair indications. Class 1 indications are moderate to severe MS with NYHA 3 or 4 symptoms when percutaneous mitral balloon valvotomy is not available. PBMV is contraindicated because of left atrial thrombus, presence of mitral regurgitation. Valve morphology is not favorable. Moderate or severe MS with moderate to severe MR. What are the complications of mitral valve repair? Valve thrombosis, dehiscence, infection, and embolic events. So to sum up the surgical part of it, if the mitral stenosis is diagnosed before pregnancy, mitral commissurotomy is preferred. If it is detected during second trimester, if it is detected during pregnancy, second trimester is the preferred period for any invasive procedure. अगर प्रेगनेंसी से पहले पता है तो mitral commissurotomy, और अगर प्रेगनेंसी में कुछ करना है तो second trimester. अब आगे, percutaneous valvuloplasty using the balloon technique has become the accepted treatment for the patients with severe symptomatic mitral stenosis. Percutaneous balloon mitral valvuloplasty provides palliation for pregnant women with mitral stenosis. Success rate is nearly 100%. Successful valvuloplasty increases the valve area to greater than 1.5 centimeter without any regurgitation. Although the maternal outcome in PBMV and open commissurotomy are the same, but the fetal loss is high in open commissurotomy. Valve replacement is reserved for cases with calcified valve and mural thrombus. अब थोड़ा सा और इसके आगे चलते हैं कि what should we try to do first, LSCS first or mitral valve replacement first. So there are specific indications if you have to perform an LSCS prior to MVR and MVR prior to LSCS. LSCS prior to MVR has to be performed if the fetus is of advanced age, you are planning an elective surgery, and the surgery can be complicated or prolonged. However, an MVR may be performed prior to LSCS if there is a hemodynamically unstable mother to avoid PPH and coagulation disorders, and it's an emergency surgery. Coming to the anesthetic considerations. Anesthetic considerations will be more or less like our goals or the cardiac grid. Control the heart rate to the low end of the normal. Avoid tachycardia. Preserve or restore the sinus rhythm. Maintain adequate intravascular volume. Avoid marked increase in central blood volume. Prevent systemic vasodilation. Avoid increase in PVR, hypothermia, hypercarbia, hypoxia, and acidosis. ये सारी चीजें HHH, hypothermia, hypercarbia, hypoxia, acidosis will cause an increase in the PVR. What to look for? Look for the severity of MS, whether there is a presence of pulmonary hypertension or not, is atrial fibrillation present or not, whether your pregnant female is in cardiac failure, are there any other valvular disease, is the patient on anticoagulants, is the patient taking digoxin or diuretics, or there are any other medical disorders associated with MS with pregnancy. This all pre-operative assessment you have to do. Goals: adequate maternal analgesia, minimize endogenous catecholamine release, tachycardia prevention, sinus rhythm maintenance, optimal preload, and as occurs in every pregnant patient, avoid aortocaval compression, avoid acute increase in the preload, avoid rapid decrease in the SVR, try to maintain wedge pressure near the baseline, limit maternal Valsalva maneuver and the stress associated with maternal expulsive efforts, avoid factors which increase the PVR, try to cut short the second stage by instrumental delivery. Caesarean section in mitral stenosis is only preserved for obstetric indication. I will repeat this line again. Caesarean section in mitral stenosis in a pregnant patient is reserved only for obstetric indications. Combined spinal epidural analgesia in laboring patient. Severe MS, normally what we do, we follow it, intrathecal fentanyl, followed by diluted epidural bupivacaine 0.125 or 0.0625, but then you have to give a larger volume, fentanyl 2 mics per ml. Intrathecal opioid in the first stage gives an excellent analgesia, provides with the excellent analgesia and avoids the sympathetic blockade. During the second stage of labor or operative delivery, epidural anesthesia and analgesia can facilitate a gradual increase in the venous capacitance to accommodate acute increase in venous return and cardiac output in the immediate postpartum period. There occurs a fluid shift. So cesarean delivery, only for obstetric reasons, can be carried out under epidural, spinal, CSC, and if indicated, general anesthesia. Technique of choice: CSC, rapid onset, analgesia is better, low dose spinal, titrated to the effect with epidural top-ups, and there provides a room for post-operative analgesia also. If you have to give GA, then it will be a modified rapid sequence with etomidate and succinylcholine. Even propofol can be used. It should be titrated to the effect. Have esmolol, fentanyl, and NTG infusions in the induction phase. Try to maintain the heart rate near normal, avoid tachycardia, prevent the laryngoscopic response. Maintain initially with 100% oxygen and isoflurane. Titrate the doses of fentanyl and muscle relaxant. Hypotension should be treated with phenylephrine boluses. Monitoring, depending upon the severity, you use all routine monitors: ECG, SpO2, NIBP, temperature, EtCO2, urine output. Invasive blood pressure, wedge pressure monitoring, CVP and TE if specially indicated. Say like mild disease and minor surgery, no need of any invasive monitors. Severe disease and surgery with huge fluid shifts, we take a A line, maybe a PSC, and we use a TEE, transesophageal echocardiography. CVP reflects the right ventricular filling pressure and is a reliable guide for left-sided filling patients, but in patients with normal LV function. In presence of a reduced LV compliance or pulmonary hypertension, this relationship is less predictable. Here we use a wedge pressure as an index of left ventricular filling. Pulmonary artery catheter, very rarely used these days. Maybe like if it may be because pulmonary artery diastolic pressures are not an accurate estimate of left atrial pressures. Wedge pressure overestimates the filling pressure because of stenotic mitral valve. Catheters, if placed, must be inserted further than the usual due to the dilated pulmonary arteries. Care should be taken because of increased risk of pulmonary artery rupture. Induction, anesthetic goals: avoid tachycardia, ketamine avoided, etomidate preferred, thiopentane propofol if titrated to. The effect can be used opioid, fentanyl, morphine with guarded use. You have to inform the pediatrician first, preferably avoid it. Nitrous pulmonary hypertension, inhalation agents. All inhalational agents decrease the blood pressure. Halothane and enflurane causes decrease in stroke volume. Both of these agents are not used now. Desflurane occasionally may cause increase in heart rate. Isoflurane, sevoflurane decrease the SVR. Muscle relaxation, again, pancuronium not usually used these days. Previously it was used, causes tachycardia. Reversal with glycopyrrolate is preferred. Atropine is not preferred. It is usually not used these days. Regional anesthesia, here like spinal, fixed cardiac output, it's a fixed cardiac output state, may result in profound hypotension. So better will be an epidural anesthesia. It causes a gradual fall in BP. So the best will be the combined spinal epidural, low dose spinal, and then you can titrate the effect with the epidural. If there is hypotension, phenylephrine is better than ephedrine. It maintains the SVR without causing any tachycardia. If you have to take a choice between oxytocin or methadone, methadone is contraindicated. Oxytocin, boluses should be avoided or not given rather. It should be used as an infusion. Bolus of oxytocin cause tachycardia. Post-operative care extends till the ICU. If the patient has to be transferred to the ICU, it does not end in the post-op period. You should keep on continuing the monitoring of the patient, provide adequate pain relief, and all cardiac medications should be started as soon as possible. Now comes an issue of, partly it has been dealt before, anticoagulants and regional anesthesia or neuroaxial blockage. If the patient is on unfractionated heparin, there is no contraindication for regional subcutaneously. If you have to give intraoperative anticoagulation, it should be given 1 hour after the needle placement, and the catheter should be removed 2 to 4 hours later. If the patient is on low molecular weight heparin as a thromboprophylaxis, needle should be placed 12 to 12 hours after the last dose. If it's on a higher dose, 24 hours after the last dose. Post-operative, if single dose, first dose after 6 to 8 hours, remove the catheter after 10 to 12 hours, restart 2 hours after the removal. Double dose, first dose after 24 hours, remove the catheter after 24 hours, restart 2 hours after the removal. This is a very small table, but with a lot of meaning. What are the advantages and disadvantages of regional anesthesia in patients with mitral stenosis or in parturients with mitral stenosis? If you are giving a neuroaxial block, it avoids a airway manipulation. It avoids tachycardia during laryngoscopy and tracheal intubation. Because pain as a cause of PVR, increase in PVR is effectively dealt. With GA, it has a disadvantage of increase in the pulmonary arterial pressure. There is less incidence of DVT. Regional dilates the vascular bud, which serves to receive the auto-transfused blood, decreases the chance of precipitating pulmonary edema. Advantage of epidural is that it can be administered in incremental doses. Total dose titrated to the desired sensory level. This, coupled with the slower onset of anesthesia, allows maternal cardiovascular system to compensate for the sympathetic block, and it lowers the risk for hypotension. So if something has an advantage, it will have some disadvantages also. See, if you give a spinal, it's a fixed output state, low cardiac output state. In situations of fixed low cardiac output, maintenance SVR is necessary. This necessitates the use of judicious vasopressors. Inability to alter the ventilation in regional may cause hypoxia, hypercapnia, which may increase the PVR. Securing an airway is difficult in face of emergency and can be challenging. Due to hemodynamic effects, individualization and titration remains the core of regional for cesarean section. Emergency precludes the use of epidural anesthesia. Though continuation of epidural analgesia into the period of labor providing anesthesia for cesarean section is an attractive option. Fine. In case the patient has to undergo on a cardiopulmonary bypass and a cesarean section has to be performed or a mitral valve repair has to be performed, how does CPV protocol differs? Routinely, in CPV, we have hypothermia, continuous flow, we keep a hematocrit low, we keep a low perfusion and a perfusion pressure is low. In pregnant patient, we keep normothermia, pulsatile flow, keep a raised hematocrit, a high perfusion flow, and a high perfusion pressure. What are the causes of mortality? If the MS is untreated, pulmonary stenosis and systemic congestion will cause mortality. Embolization 20 to 30%, pulmonary embolism 10%, and infection in 1 to 5%. So to sum it up the whole of the thing, I will tell you very salient points. A pregnant patient with mitral stenosis, when there is an increase in transmitral gradient associated with clinically significant mitral stenosis, more time for diastolic filling is required to ensure adequate preload. Heart rate is inversely proportional to the diastolic filling times. So therefore, that's the reason low heart rates are recommended. The decrease in diastolic ventricular filling time is associated with pregnancy-induced tachycardia, which increases the left atrial pressures. The increase in transmitral gradient can be further complicated during labor. Tachycardia can result due to pain or maybe due to tocolytic therapy, which further decreases the diastolic left ventricular filling time. तो यहाँ पे हम बात कर रहे हैं mitral gradient का बढ़ना, हार्ट रेट का इनवर्सली प्रोपोर्शनल होना डायस्टोलिक फिलिंग टाइम के साथ और पेन के साथ टैकीकार्डिया होना, बीटा टोकोलाइटिक थेरेपी के साथ टैकीकार्डिया होना. Other points to remember is if you give neuroaxial blockade, it's a fixed cardiac output state, vasodilatation can occur, it will lead to reflex tachycardia. So our hemodynamic goals, maintenance of normal to high preload, afterload and contractility. Significant decrease in SVR which results in reflex tachycardia are poorly tolerated. Accordingly, in case of hemodynamic instability, vasopressor of choice, which is phenylephrine, should be tailored to achieve these hemodynamic goals. Epinephrine should be avoided, causes tachycardia. Phenylephrine restores the hemodynamics. It does not cause or causes very little unwanted effect on placental perfusion. The use of norepinephrine may provide additional inotropic support without increasing heart rate. There is, ये line भी काफी important है. There is no evidence-based guidelines which describes an anesthetic technique which is optimal for pregnant patients with mitral stenosis for labor analgesia, anesthesia for cesarean section. काम की बात क्या? Timely provision of analgesia and anesthesia is essential for reduction of peripartum morbidity and mortality. Expert opinion is that the choice of anesthetic technique must be individualized. It depends upon the understanding of the physiology of pregnancy and its interaction with the individual patient's pathophysiology, including lesion severity, and understanding of the impact that any pharmacological therapy will have on the peripartum anesthetic care is essential. Alterations occur in the hemodynamic status even after 24 hours of delivery. So cardiac monitoring should be maintained from the peripartum period into the postpartum period to reduce the morbidity and the mortality. Thank you.
Thank you, Puneet bhai. लोगों को ये लगा होगा people are getting that to see you in video as a funny kind from UK.
Sandeep, पता नहीं COVID क्या कराएगा, पता है? Almost it was a month. I had joined COVID duties on 4th of April. We had the first patient. I'm talking of 2020. Or I was relieved of my duties just in the first week of March. ठीक है, और अभी I have been called back again. अभी hardly एक महीना निकला है और दिल्ली में फिर बम फट गया है. अभी मेरे सेंटर पे 170 मरीज हैं आज फिर से.
So we see you in different shape after some time.
चलो, I think I थोड़ा फास्ट कराया, आपकी बारी थोड़ा छोटा कर दिया था. ठीक है.
It's very nice and crisp because we are discussing 4 lectures in pregnancy and we have taken almost all aspects that you can get as a theory and practical. And we will say that if we have questions, we can take. Meanwhile, I was in the chat box, I am taking the questions. People have, why not? Because you know that like PPH or placenta previa that can cause PPH or the cardiac patient, why we want to give spinal? Because our funding should be clear. The anesthetic consideration, we should know what is my patient, what is the pathophysiology in that patient, and what is the pathophysiology of my anesthetic technique. Means if my anesthesia technique is fighting with the pathophysiology of patient, I should not practice that. It's not the case report or case series you have to present in exam. You have to present well-established fact. So no spinal in mitral stenosis, severe mitral stenosis. Especially if the patient had severe PH, a patient in AF on anticoagulant, we can safely give analgesia and required sensory level of anesthesia with standard epidural practice. So I think we are now more wiser. Another question was the comparison of whole blood with the component. The components exclusive has 20-30% higher platelet, coagulation factor, fibrinogen as compared to whole blood. Although if you mix everything, one FFP, one cryo, one platelet, one PRBC, the volume will be higher than the whole blood. But why we are giving component therapy? Why we are giving platelet, cryo, and fibrinogen? Because we want to have coagulation factor and platelet somewhere. And when it is 20 times means 20%, 30% higher in component, then we should give only component. So don't give your answer like choice of technique in exam that is coming from case report. Like you have just read in a journal, a severe spinal, severe mitral stenosis patient. You have to see what is the other component of that patient. What is the hemodynamic of that patient? What is the requirement of that patient? You can't give one answer for every patient. That's why we have to give the answer that are safe, that are standard, that match with the pathophysiology, that is not contaminated. So if we have any question, we can ask here, direct or on the chat. Till then, we have few slides left by Professor Salah Ali Madam. Professor Salah Ali Madam is there. Professor Salah Ali is there. So if we have questions, we can very well take your questions. I am saying that in exam means standard balanced anesthesia practice. So now we are wiser with exclusive this 5 to 8, almost 3 hours on pregnancy. And this long case should not have whether it is coming in the practical and theory exam. All of you can raise any voice or question or suggestion or comments. Dr. Kushwaha, yeah.
Yes.
बॉस कुछ ऐड करना चाहेंगे आप, क्योंकि आप डॉक्टर कुशवाहा is a cardiac anesthetist and he can add on if something is left.
एक्चुअली डॉक्टर पुनीत ने सभी कुछ इंक्लूड कर लिया है, बट एटलीस्ट जो पहले उन्होंने कहा है कि वी हैव टू सेट द गोल्स एंड वी हैव स्टिक टू दैट गोल्स. दिस इज द इम्पोर्टेंट.
वेरी गुड. सर ने कहा कि पहले आप अपने पेशेंट की पैथोफिजियोलॉजी, आपका एक्सपीरियंस, आपकी टेक्निक और उन सबको मिला के अपने यू हैव टू establish 1 2 3 4 points anesthetic consideration that you want to achieve in this patient, and which technique, which drug, which monitoring will help you to achieve that goals is the crunch. That is the way. So now we have Professor Saila Halim madam, who is discussing the left out slides, and after that we will be over in next 15 minutes. Thank you, ma'am.
Okay.
We are getting you.
As you know that I am already discussing about the obstetric emergencies. The causes which I have already discussed are the obstetric hemorrhage, postpartum hemorrhage, eclampsia, severe eclampsia and the complications, and uterine rupture, amniotic fluid embolism, and also the one important cause which I have already the severe sepsis. And you have to manage with this. Just I have shown it because these patients, before it, that these patients to be managed immediately in the ICU, and with the antibiotic coverage and monitoring, with the invasive monitoring and everything, and vasopressor support, they have to be managed. Now this, the left part is the obstetric trauma. You might get the patient in the emergency and you get the call for the patient having a trauma because of the road traffic accident or because of any accident, and patient develop the trauma with the pregnancy, and you have to manage this patient keeping in mind that you have to take the opportunity of golden hour, and within this golden hour time you have to save the life, especially the first 10 minutes, which is known as the platinum time, and you have to resuscitate your patient within and stabilize your patient within 5 minutes and take the active management within 10 minutes of this stabilization and resuscitation. So according to this, I have made a chart algorithm. Whenever you get the trauma victim in the emergency department, you have to, according to the ATLS protocol, you have to resuscitate the patient, ABCD. You have to check airway ventilation and cardiovascular stability you have to achieve, provide the left atrial tail, and if you are suspecting hypovolemia, aggressive resuscitation is to be done, and take the 2 life, and if the patient having a raised ICP, and then maintain the cerebral perfusion. Any problem, Dr. Sandeep?
You continue, please. We are saying that we are getting.
Okay. Suppose in the meantime the patient develop the cardiac arrest, this should be done, the perimortem cesarean section to be done to save the life of at least and this fetus. Then the one very important cause of the obstetric emergency is the cardiac arrest. Sometime when the patient reach to the hospital from the faraway places, develop the cardiac arrest, and you have to manage as an anesthesiologist. So what are the causes of the patient who develop the cardiac arrest? There are the obstetric causes, especially the complication of preeclampsia and eclampsia, amniotic fluid embolism, or even the massive hemorrhage, and anesthetic complication may also sometime from the other place you will get the patient as a this cardiac arrest. There may be patient having a cardiomyopathy with the parturient patient with the cardiomyopathy, or you may get the pulmonary embolism or cardiovascular. With the cardiovascular diseases you will get. So incidence, how will you take care of this? There is a teamwork. So there is an important team that you have to allocate the team, every member of the team, they work. There is a core team leader. There is a person who specifically manages the airway, provide the oxygenation and ventilation. One person especially allotted for the chest compression, and one person has to take care of the vascular access, and one person has to administer the drug, and one person has to prepare the drug also, and one has to record the each and every events, and obstetrician has to perform the immediate delivery, and pediatrician has to take care of the infant. So there's a lot of personnel they are required for the management of the cardiac arrest victim, and this is a dire emergency, and blue code has been already activated. And then there is a question arises, how will you provide a left uterine displacement? There is a two-hand technique, or you can even displace the uterus with the one hand. So this is the one, sometimes this is asked the resuscitation of the cardiac arrest victim, especially the pregnant mother, where you have to do the displacement of the uterus. This is the two-hand technique, one and two-hand technique. So the algorithm for the ABCD survey, and then you have, as you are proceeding for the cardiac arrest victim, check responsiveness, activate the emergency medical system, and ask for the AED, and maintain the airway, provide the patent airway, and maintain the ventilation, and circulate chest compression to be immediately without interruption to be started. And you have to ask for the defibrillator, and check the rhythm, whether it is a VFVT. If it is a VFVT, means it is a shockable rhythm, and you have to give the shock. So secondary survey, ABCD, and in the meantime, you have to. So for the perimortem cesarean delivery, suppose you are getting a patient with the CPR with the uterine displacement, what is the guideline? If the patient having a less than 24-week gestation, then you have to continue CPR. And fetal consideration, they are secondary. If the patient having a more than 24-week gestation, then this to be done by the perimortem cesarean section within 4 minutes of this cardiac arrest done. Suppose the patient is still not be able to resuscitate it, then direct cardiac massage or the bypass should be done within 15 minutes of this. So there is also a guideline in the 2020 this AHA. According to the AHA, you have to provide the high quality CPR. You might be knowing what is the high quality CPR. That is a push hard, push fast at the rate of 100 per minute without any interruption, adequate chest recoil, and with the ratio of 30:2. So you have to follow along with this high quality CPR. Defibrillator is also very much required, you immediately to be available, and you have to give the high flow of oxygen to the patient. And there are some changes they have done. What is that? Always secure the IV line in the upper part of the diaphragm, especially in the pregnant patient, and this compression to be done above the level of nipple in the pregnant patient. So this is the important in the pregnant patient. And also they have some new added is that they have put the ABCD, EFGH in the this ACLS protocol of the pregnant patient. Is A for the anesthetic complication you have to keep in mind, especially when you are dealing what are the causes or what are the which lead to the cardiac arrest. Always keep in mind the anesthetic causes or complication. Second is the bleeding may lead to the cardiac arrest, so you have to take care of this. Bleeding means hypovolemia. Cardiovascular means associated cardiomyopathy, and then you have to accordingly you have to manage. If any drug like local anesthetic toxicity, then it also be managed accordingly. If there is you are suspecting embolic, then also fever. And G they have taken for G is the 4H or 5H and 5T. 5H and 5T you might already have memorized it. 5H you are know that hypoxia, hypovolemia, and hydrogen ion, and this hypothermia, hypo or hyperkalemia. T is the toxin, tamponade, and cardiac tamponade, and thromboembolism, coronary, and the pulmonary thromboembolism. So these are, and tension pneumothorax. So you have to keep all these 5H and 5T always in your mind, and during the management of this cardiac arrest victim, especially the tension pneumothorax and patient having history of trauma, then also accordingly you have to manage the patient and hypertension. So this is the nutshell of the obstetric emergencies, and thank you very much and good luck for your examination. Thank you once again. Any question you want to ask, you can ask.
Yeah, thank you, ma'am. Thank you very much for your very nice presentation and slide. I am getting message regularly since your talk that we need slides of madam. So definitely all will get the slides after the course. But now this time to learn the subject.
Dr. Sandeep, you know that I have prepared only 2 days. 28th night, I got the message.
Yeah, yeah. But you are always.
So it is not up to the, according to me, that is not too good.
But it is more than the needed. If our student learn this much and they speak even 25% of what our speakers have say, you are more than pass. So now you have to understand what is the problem if somebody is not getting pass means 1/4 of the today's knowledge is not being talked by you or not practiced by you. That if you not talk, we assume that examiner assume that you are not practiced that. You not practice means you are not thought of even read of that thing. So I always say to all these students, you are better brain than us. You are the new generation. You are the technical more sound than us. You have more information and knowledge than us. So be better more than us. And we believe that you will do, and very thankful for day 1. And to even this time also we have 100 people are connected online on YouTube and Zoom. So I will appreciate all speakers for their very nice presentation and their hard work they have presented and their knowledge skill they have shared. So if still we have any question, we can ask. If we don't have question, we have the number of the presenters in scientific program. You can ask between suitable time, morning 10 a.m. to 5 a.m. anytime, or for me at any time that you want to ask. So if we don't have any questions, it's time to say bye-bye and good night and enjoy your Sunday after this hectic afternoon and evening. Thank you. Bye-bye. See you tomorrow.
Thank you, Sandeep. Thank you.
Thank you, Puneet boss.
Thank you.
Thank you, chairperson and speakers.
Thank you once again to you.
चलिए दुआ करते हैं जल्दी मिलें सारे. ठीक है,
चलिए सब लोग ठीक रहें और फिर जल्दी मिलते हैं बस. Thank you. Bye bye. It's time to leave. I am